So we want to welcome everyone to the Right Care Initiative Virtual University of Best Practices. We believe we have a very exciting program today, and we have some very interested speakers who will be presenting information that is actually somewhat new, so that we're looking forward to that. We have a great group here. We will give everyone a minute to literally make sure they get on or log on. There will be a time right now to thank our sponsors and supporters. The Right Care Initiative does receive support from a number of groups. It is a UC Berkeley Public Health, Blue Shield is an important sponsor, CDPH, and the rest of the sponsors here are shown, including a group that focuses on stroke awareness, the American College of Cardiology, California chapter. And then we have corporate sponsors as well as our institutions of UC Berkeley, Stanford, and University of California. So we're happy to welcome everyone today, and we will be proceeding in a short period of time to our first speakers. We want to introduce Ed Yu, who is our associate from the Bay Area. Ed is certainly the important person in Palo Alto as the Chief Quality Officer and has been there for years, driving up the healthcare improvement process in the Bay Area. He has multiple initiatives in population health and has a lot of experience in patient safety and is a vital role in running a very large multi-specialty group practice for the Bay Area. And he is a family medicine board individual and graduated from UCLA. So at this point, I'd like to introduce Ed, who is then going to introduce our Air Force team for the first set of presentations. Ed.
Oh, thank you very much, Bill, for that warm introduction. Just an audio check, you can hear me?
Yes.
Okay, thank you. I'm having some visual issues. I apologize in advance that I can't get on Zoom, and I'll try later. However, I would like to, on behalf of the Bay Area Right Care Initiative, want to welcome everyone to this call. I will start by just giving you a brief overview of our agenda. We have two major speakers today. One, we're going to hear about the latest information about heart disease. That will take 45 to 50 minutes, and then that'll be followed up with another talk on the topic of the year right now, the role of COVID-19, and we'll introduce the speakers as we get closer to that. So unlike our other items, we are having two longer sessions of these two important topics, and we certainly look forward to the discussion. But before we jump over there, I just want to review again what the Right Care Initiative purpose is. Our goal here is really reducing the bad outcomes for our patients of heart attack and stroke by optimizing and preventing the chronic conditions that lead to that. And this triangle represents the cornerstone of our framework of how we do so. We're leveraging a team-based approach with standardized protocols and with proven population health workflows to achieve the outcomes that we look for. Next slide. This gives us some of the data that you may have seen. Again, I'm just showing Santa Clara County information. First graph up there is blood pressure control for patients with hypertension. Second graph there shows blood pressure control with patients with diabetes. And these are some of the larger healthcare systems in the county, and in general, you can see our performance over each bar is performance of a calendar year. you can see that at least we're maintaining and improving the performance over time, and that exactly is the goal of the Right Care Initiative. Next slide, please. This is a relatively newer metric to us, is to recognizing with diabetes, cardiovascular morbidity and mortality is actually one of one of the complications that diabetic patients have, and one of the cornerstones is to optimize cholesterol control by having our patients on statins. This is a view of our performance over time on this particular measure as well. And again, the sessions that people attend here adds to the knowledge that we have to optimize the performance with the goal of decreasing the disease burden and also optimizing the health outcomes for our patients in our community. So to show us how to do so, gives me great pleasure to introduce my counterpart, who is a co-chair of the Right Care Initiative in our area here, Dr. Joe Skye. He's a cardiologist. In fact, he's the chief of cardiology and the medical director of the Health, Lung, and Vascular Institute at the U.S. Air Force Medical Center up in the Travis Air Force Base. He's a well-spoken speaker and just a esteemed clinician with a world of heart. And I've been working with him and learning from him in the past few years. And I'm just delighted to have him here to introduce one of our keynote speakers today for our first topic. So Joe, I'm turning it over to you to introduce Dr. Davenport. Thank you. Hey, Joe, are you on the line? Are you speaking? If you are on mute.
There we go. That's better now?
Yes, thank you. Gave me a heart attack almost.
Okay. Well, it is my pleasure to introduce Dr. Davenport, and he is the Chief of Cardiology at the U.S. Air Force's School of Aerospace Medicine and a small division called the Aeromedical Consultation Service. And that small little division there has a huge responsibility that started with the space program. For any of you who've seen the talk I've given on that history, Dr. Davenport is the current leader of that tremendous history that started with John F. Kennedy's vision when the school was dedicated, that all of us would benefit from the science that was developed from the space program. So Dr. Davenport trained as a cardiologist in the Air Force and went on to be selected by our common mentor, Dr. Bill Cryer, one of the world's experts on aerospace medicine, now retired for many years. And Dr. Davenport was selected to lead the cardiology program for the U.S. Air Force. And that role is important because, as you might imagine, that role naturally lends itself to also be a leader for the federal aviation and for the NATO organization. And in fact, Dr. Davenport has taken very impressive leaps forward in working together to form new collaboratives for objective data collection and programs. And so today we're lucky enough to be able to hear his presentation on the current state of aerospace medicine for Air Force pilots. And I look forward to hearing his talk about why Air Force pilots don't get heart disease. Thanks, Eddie.
Thank you so much. Let me share my screen here. Well, first I gotta bring it up. There we go. It is an honor to be here. Thank you so much for having me. I wish I was actually there in California. Are y'all seeing that? There we go. Do y'all see that?
Yep.
Wonderful.
Yes.
It's starting. Yes, now your slides are up. Thank you.
Heroes with heart disease. Good, good. Well, thank you so much for letting me talk today. It is neat. Like I was telling Joe, I'd rather be there in California, but welcome to Ohio. What's so cool about the Zoom is it feels like you're here in my house. You know, I'm like, I just tucked the kids into bed. It's about 3 hours later here, and we get to sit down and grab a cup of coffee, glass of wine, pull up a chair, and we'll talk about preventing heart disease. It's really cool. So again, thank you so much for having me. As Joe said, yes, I am at the School of Aerospace Medicine. He was there before me, so I'll give him some props later in the talk here. So Erie Air Force, Air Force Reserve, Air National Guard member that has any type of heart test done, it comes through my office. Anyone with any disease that wants to be on flight status will come through our office to see if they should be flying. So we use a lot of data. I've been blessed enough to actually get to work with folks from all over the world. I'm the SG consultant for this. I'm a chairman of a NATO working group. So that's a cool trip to Paris every year where we all meet and do the same sort of thing for 9 countries. And then also a federal air surgeon consultant, and then work a little bit with NASA. And then, so we get to do lots of cool things, a lot of cool research. And what's cool about my research is that it's done in us. It's done in everybody on this call. I'm not looking at sick people. I'm looking at preventing the disease, or if they get the disease, can they go on to fly airplanes? And so it's a pretty neat job. The other cool thing about today is you all invited me to give this talk, which is awesome. I wasn't sent here by the Air Force. I wasn't sent here by the FAA. I wasn't sent here by NATO. So tonight we can just talk about what I've learned. So what I hope to do is show you kind of a little bit what I do, talk about how we want to prevent cardiovascular disease in our aircrew. And then at the very end will be the kind of the coolest part, I think, because I'm going to show you a few little risk factors you might not have thought of that could prevent heart disease. So this is just my standard disclosure slide. These are all approved slides for the Air Force. But everything that comes out of my mouth tonight is not that of the Air Force. It's purely mine based on what we've learned. So everybody knows this slide right here. You all are, I'm preaching to the choir right here, right? This is cardiovascular disease, #1 cause of death. It's also the #1 cause of death in pilots and astronauts. Before we're done talking tonight, there's going to be about 200 people die of heart disease while we're doing this meeting. It's very common, but you may not know it's also the leading reason for diversion on flights. There's over 200 a day, and they just published this last week. It just came out at about $38,000 per diversion. So it's something we need to be talking about. The other thing I like to remind everybody, because I take care of a lot of young folks, young pilots. So I have a lot of 30-year-olds. I have some late 20-year-olds that have had heart attacks. I've had aborted sudden cardiac death. I've had a person get 100% on their PT test, go through the finish line. A PT test is physical fitness test for your non-military folks. So it does his physical fitness test, goes through the finish line, scores 100% and drops dead, gets resuscitated, has 100% LAD lesion that gets stented. And you say, why did that guy have heart disease? That's what I want to know too. And that's what we'll talk about tonight. And that's what we see. It's not a disease of old age, as I say here. The majority of those folks that have cardiovascular disease are under age 65. They just published a study not long ago that the most common cause of sudden death in our active duty military is atherosclerotic cardiovascular disease. It is not hypertrophic cardiomyopathies or any of those other things you might think of. And the hard part about flying with heart disease is the most common cause of death, the most common presenting symptom is sudden cardiac death. So that's not good. You can't pull that airplane over and have your heart attack. That's not a good time to have your heart attack while flying airplanes. So as Joe told you, this is where we used to work. This is Brooks City Base down there in San Antonio, Texas. It used to be Brooks Air Force Base. And ever since the inception of the Air Force, there was something called the Central EKG Library. All cardiac testing went to this EKG library. It was at Randolph Air Force Base for a while, moved down here to Brooks. As Joe told you, Joe Sky, that right here at this was the School of Aerospace Medicine right out here. John F. Kennedy dedicated this building back in 1963. This is the School of Aerospace Medicine. I worked right here. There was a guy long before me, during this time, there was a guy there named Dr. Lamb, Lawrence Lamb, very good friends with then Lyndon B. Johnson. In fact, Lyndon B. Johnson would come in all the time, land his helicopter right here and go hang out with Dr. Lamb. As you can imagine, he must have had some cardiovascular disease, right? So he would be always there. But because of that, Kennedy loves USAF-SAM just like Lyndon B. Johnson. And as Joe Sky's probably told you, he dedicated these buildings as the School of Aerospace Medicine there in 1963. The next day he flew up to Dallas, and that's where he was assassinated. So his last official act as president was to dedicate these buildings. But it's so beautiful there that they decided to move us here. We're now in Dayton, Ohio, right? Patterson Air Force Base. And that is my day job. When I tucked the kids into bed, I took off my uniform and then I came here. This is where we're at now, right? Patterson Air Force Base. We moved here in 2011. We've been here since. We still have that same database though, over 60 years of data. Outcomes are based on that data. So again, we can't look at old people dying of heart disease and try to make policy in the Air Force, because our folks are more like athletes. We follow the athletes guidelines more than we do the regular guidelines. But we need to use our own data. We have 3 types of flying classes. Some people are pilots and they want to become a pilot in the Air Force. So if you've got cardiovascular disease and you want to become a pilot, that's a hard call, right? That's a flying class 1. We're probably going to say no. But if you develop heart disease after you're a pilot, then maybe we'll let you stay. And that's a different kind of flying class. Then we have non-pilots. We have boom operators, the ones that get down on their bellies and refuel the planes. And we have a lot of the person dropping the bombs in the back of the plane. So these are different flying classes, but they all have to come through our office to make sure that their heart is okay. And so we get a lot of EKGs, a lot of echoes, a lot of treadmills. That's my daily job right there. But someone had this funny idea back in the early 2000s to come up with a way to keep all this data in a digital format. So back then, there was something called the Picture Archive Communication System. You've probably heard of this PACS. It's been around a long time for radiology, but not so long for cardiology. And so back in the early 2000s, Joe Sky said, hey, we got to come up with a way to save all this data. It was sitting around in boxes. It was sitting around in microfiche. I remember I had to go to Walmart one day on the way to work to get a light bulb so I could look at some old EKGs on the microfiche. So he decided, hey, we got to get this picture archive communication so we can start doing all these echoes and save them in a digital format. Save the EKGs in a digital format. So he decided to get a bunch of your taxpayer money and get a picture archive communication system and digitize all this stuff. And he did that. When I got there, I said, what about this up here, though? We got 1.2 million old studies. We got to get that in there, too. So we did that. We digitized all the other stuff that was laying around on the floor. So everything we had new and all this old stuff was getting in there. And I think that was all part of Joe's plan. The other thing that took forever, though, is to get stuff to us. So we had to mail it, snail mail. So by the time we got an EKG on a pilot, you mail it to us. It'd get there in a week or two. We'd say, oh my gosh, this EKG needs an echo. We'd write a letter. They'd mail the letter. They'd get the letter in the mail. Then they'd say, oh, we're going to get an echo. And they'd get the echo. And then they'd mail it back to us. Well, if it's all digitized, why do we have to do that? So I decided we should do this all digitally. So in 2012, we did the third phase of this project and we digitized everything. So now we have 208 flight medicine clinics throughout the world. I've got studies today. I got a study from Australia. I got a study from Japan. Got a study from Korea. Those were all just today. And so they send those studies. So if you get an EKG anywhere now at any flight medicine clinic, you press a button, it pops up on my screen there at USAF SAM. By 1600, which is 4 p.m. every day, I've read every study that comes in to see us, and then we can disposition it. And so that's what we're doing now. And then we added things like 3D echo. So we like to do nuclear stress tests on everybody in the past, which I'll explain why that's not the greatest idea. We moved to 3D echo. So as technology advances, we can now do imaging stress tests and people all over. So how do we decide who gets to fly? Well, we use our own knowledge of flight physiology. We have the whole School of Aerospace Medicine here. We do research. We use published data. We use the athletes' data, usually because our air crew are younger. And then we use our own database. And that's where we can use those 1.2 million studies on 300,000 air crew. And then we work with other countries. So one thing I wanted to do as soon as I got here, they sent me to a couple conferences overseas. I said, everybody's got this data, so we should all be doing this together. I'm the only one that does this full time. So my full-time job, day in and day out, is aerospace cardiology. That's all I do. Everybody else is an additional duty. So I'm working now with the Army, Navy, Marines. Actually, we're having a big meeting next month about coming up with one big, happy aerospace medicine guidelines, such that, we have something called the DHA now. It's a 4-letter word for us that are in the military, but they're combining all the different branches of the military into one medical system. So I say we need to do that too for aerospace cardiology. I also work with FAA. I did get appointed as a federal air surgeon consultant. So the FAA, that's all your commercial flights. Now, a lot of my pilots are guard. So if we have a guard or reserve pilot, he might fly F-16s on the weekend, and he's flying your United Airlines flight or your American Airlines flight during the week. So my wife always makes fun of me when I go to the airport. Sometimes a pilot will come up to me and say, hey, Dr. Davenport. And my wife's like, I'm not getting in that plane. I'm like, no, honey, that's the plane you want to get in, because I know he's okay to fly or he wouldn't be flying, right? So I said, let's work with the FAA. So we work with the FAA now. We work with Europe a lot. I went to a meeting out there, met a couple great folks over there, cardiologists in the Royal Air Force. And then I met some in the Swiss Air Force. And before you knew it, we came up with a working group of a bunch of us at NATO. Also work with NASA. We had a guy having a lot of PVCs one time, and they were nice enough to call me. We did a stress test on the space station, and I did it right here from my office at home, because the one at the work, of course, government computer couldn't get on, but this one did fine, got on and actually ran that from here. So that was pretty awesome. We're looking at astronaut selection. We're looking at missions to Mars. SpaceX actually is, as you know, is sending people into space, sending passengers into space. I took my kids down to the space station, or not space station, I wish, took them down to Houston while we were there in Texas. And it was really nice. We got to tour all of Houston. I got to take them to mission control, and so they got to see the real mission control. And somebody came up and asked me, said, "Hey, I want you to look at this EKG on the SpaceX guy." And I was like the hero for my son for like a month. He was like, all he talked about is dad's working for SpaceX. I've never met anybody from SpaceX. I'd love to work with them, but you know that's coming, right? You know, by the end of the year, they're going to be sending people up in space. You know that we just put that rover on Mars, and Elon Musk with SpaceX says he'll have somebody on Mars by 2024. So it's a real exciting time to be in aerospace medicine. And it's a real exciting time to be in aerospace cardiology, because I got to make sure that your heart can make it up there, because it's a long trip back, right? So this is all the folks we get to work with right now. I am the chairman, along with Joe Darcy up at the UK in this NATO working group. This is a wonderful group of folks where we're all trying to come up with evidence-based guidelines for cardiovascular disease. And specifically today, we're going to be talking about prevention. This is one of the textbooks that are out there that I was lucky enough to get to work on. And I'm even more proud possibly of this right here. This is a 9-nation document. That's that NATO working group. Ed Nicol over there knows a lot of people at the British Cardiovascular Society. So we got to do this supplement, which is pretty much guidelines. We want to come up with guidelines for heart disease, including prevention in aircrew. So we came up with this. It's more of a consensus, because as you know, recommendations got to have some level 1 evidence. We just don't have that yet, but I'm getting there. I'm getting there with all that data that we're now getting to publish. The good thing about COVID is, while everybody hunkered down at home, I went through that 1.2 million studies, and I came up with about 5. We got 5 manuscripts will come out in the next year, thanks to COVID, because I had nothing else to do but to go through that. Now I'm getting all these pilots that had COVID, but we'll save that for Dr. Bommer. He's going to tell me what to do with that in the next talk. So now this is my vision for aerospace cardiology. I've got 1.2 million records, but working with the FAA and working with my friends overseas, we've got about 5 million records. We've got over 3 million aircrew. All those EKGs that the FAA still has you fax in, they're all in a database. It's just amazing. It's a great database. And so again, this is going to be able to let us know how we can prevent cardiovascular disease. And just a little piece of how you can do that, I'm going to share with you tonight based on these folks. So what do I want to do? I want to come up with a cloud, right? Put it in the cloud. We'll put all this data in the cloud. We'll ask questions. I got a text today asking about a carotid artery dissection and a high performance pilot for one of my colleagues overseas. And so we can send stuff in a cloud. Would be a lot easier than what we're doing now. And then we can disposition not only our military aircrew. You know, this is my full-time job. I'm working some with the FAA, but we could do everybody. We could do everybody in the military, all high-risk occupations. How about our firemen or paramedics? And so this can include a lot more people. And finally, we are developing an app. There's an app for everything, right? We have an app for high-risk occupations with cardiovascular disease that we're developing right now. And so you might say, well, yeah, we don't want these folks getting heart disease. We don't want anybody getting heart disease, right? And again, this is the choir I'm speaking to right now. But why is it a little bit more important in our high performance or military aircrew? And this is one of the reasons why we fly high performance. So one of the great perks of this job is I get to fly in some cool things, right? I've flown in F-16s, T-38s. I've got to fly in Blackhawks, lay on my belly, refuel airplanes. And it is one of the perks of the job. But the reason they have flight docks in the Air Force and in the US military, pretty much exclusively, but all our flight surgeons, we fly with the folks we take care of. And why that's important is because I know what it feels like to pull 9 Gs. I know what it feels like on my heart, and my young and, as knock on wood, healthy heart. It's rough. It's rough. Why? Because when you start pulling Gs, all that blood that's supposed to be going up into your heart and out into your body is going right down to your feet. So one of the cool things we have here, I've got lots of toys. I've got altitude chambers and I've got a centrifuge. And the centrifuge is where we put you in there, we spin you around, and we simulate that G that goes down your legs. And it's a beautiful contraption. It's an evil contraption. I wish I could spin my kids in it when they were bad. Because what happens, you get that thing, you start pulling G's, all that blood is not filling your heart. Remember, the more you fill your heart, what we call preload, the more you fill it, the harder it squeezes. If it's not filling all the way, it's not squeezing as well. So your body knows that. It tries to increase your heart rate to make up for that. But the centrifuge, the F16, the F22 always wins. That stroke volume goes down. So now let's give you like a 50% stenosis in a major coronary artery. You might be able to do a full Bruce protocol. You may be able to do your stress test, right? You can do a stress test just fine. But can you pull 9 Gs with a half blocked artery? I don't know. That's the data we're trying to figure out. And then there's negative Gs. That's where you hang upside down. I like doing that a lot. When I'm flying, when they give me the stick, I like to hang upside down a lot. I found out pilots don't like it. They usually take the plane away from me when I do that too much. But what happens there is you get all the blood rushing to your head. Kind of important, believe it or not. In space flight, if you've ever looked at anybody who's been on the space station for any amount of time, their head is a little puffy. Actually, the stroke volume goes up and the heart rate goes down. So we have some marathon runners. You put them on the space station, you put them up in space, their stroke volume goes up, their heart rate goes down. It's all this normal physiology. So all these folks, in short, just better have really good hearts. This is just a table showing you as you pull more and more Gs, your stroke volume goes down, down, down. Your heart rate tries to go up, but your total cardiac output always goes down. So they say a picture's worth 1,000 words. So here's a picture from my German colleagues on a poor monkey they put in a centrifuge. This is the monkey at 1 G. Look at that heart, 2, 4, and at 6 Gs, it is just not filling. That's hard. So how do you overcome that? You do what's called the anti-G straining maneuver. You're pushing all the blood vessels in your leg, straining to get that increased flow back to your heart. You have a G suit that fills up and increases the filling of the heart. But in all these situations, you can see you want a healthy heart flying in that airplane. You want a healthy heart. So how do we disposition folks in the Air Force? We have this 1% rule. Why do we have a 1% rule? Because that's the rule for the airplane. There's a 99% chance that airplane is not going to have an engine fly off of it like happened earlier this week on that the 777, right? There's a 1% chance there could be something mechanically go wrong with that airplane. So we give the same 1% chance to our aircrew that fly in it. So that's a pretty high threshold, right? If you have more than 1% risk of sudden incapacitation, you cannot fly. That's only over 10, 20 years. So when you look at other cardiovascular diseases, not coronary disease, some of them are not going to hurt you bad when you're young, like the mitral valve, different valve diseases. They might hurt you later on in life. You can still fly for 10 to 20 years if we monitor you closely. And then the other thing we look at is if symptoms come up that preclude mission completion. That's a big deal in the military. If you're going over there to get the bad guys or pick up the good guys and you're having angina or palpitations, you got to turn the plane around. That's a very bad thing, right? Bad things can happen. People will die. So in the Air Force, we can't have you turning around the plane at all. Also, the impact of standard of care on medical therapy. So as the as medicine gets better, as our stents get better, as we can decrease the cardiovascular disease risk, secondary prevention and primary, we can get people back flying sooner. So I do all the waiver policy for the Air Force. I write all those waiver guides along with other folks, and those change every month or two. We have a new one come out as the guidelines change. And then also special considerations. So say you have some coronary disease, maybe I don't want you flying F-16s, maybe I don't want you flying F-22s high performance, but maybe you can fly a cargo plane. And so that's the third thing we look at. So all this was just an introduction to say we need to screen our aircrew for heart disease. I think everybody would agree with that, right? Even though we're getting better, we're getting better. We do know that the death from coronary disease is going down. We're finding out chronic illness, though, believe it or not, if you've read anything lately, not just COVID, but all chronic diseases are getting a little worse. So what we're finding out is we're living longer, but we may not be living better. Does that make sense? People always say you're going to get old and die. And I'm like, nope, you're going to get old. You're going to live a long time and then you're going to die. So that long time, we want to be some quality of life. And that's why you all, that's why your organization is so important. So this is just to remind you, it affects pilots just like everybody else. Cardiovascular disease is the #1 cause of death in everybody in the world. So, or in industrialized nations. So, and again, these are the things we find when we do any type of studies, and this has been done here in Europe and throughout the world. So here's a problem with heart disease. You're alive, then you're not. Yeah, That makes it kind of tough, right? So what do we got to do? Well, we used to do stress tests on everybody. So in the old days, if you came to the Aeromedical Consult Service, which I just talked about cardiology, I tend to just talk about cardiology, but they do everything there. We do all the eyeball stuff. So all the ophthalmologists, so everybody who wants to be a pilot comes there and makes sure that their eyes are okay. We do neuropsych testing to make sure they do IQ tests and all that stuff, both for baseline. So if anything should change, we can go back to those baseline. But we do a lot. We have a specialist in virtually all subspecialties at the School of Aerospace Medicine and the Aeromedical Consult Service. Now, in the old days, we thought we should be screening for cardiovascular disease. So what do we do? If you came to the consult service for any reason whatsoever, we would do a stress test on you. So you could come there because you were blue-green colorblind and leave with a 5-vessel bypass, right? You go there, you're going to get screened. So what we did is we screened everybody, and we found a lot of stuff. But here's the problem with doing a stress test as a screening for coronary artery disease. Even if you take a good test that's 80% sensitive and 90% specific. So if you remember back to your med school days or from your training in sensitivity and specificity, sensitivity is the likelihood of a positive test in somebody who has the disease. And specificity is the likelihood of having a negative test in folks that don't have disease. The problem is if you have a very low prevalence, even if you have a good sensitivity and good specificity, they're still not good tests. For example, let's take 20,000 folks. If I take 20,000 folks and there's only a 5% prevalence of cardiovascular disease or coronary artery disease, 5% of those 2,000, only 1,000 will have actual heart disease. The other 19,000 will not have heart disease. So even if I have a great test that's 80% sensitive, 80% of the time, when I do that test, it will be positive in somebody who has the disease. So their true positive rate is right here. 800 will be truly positive, but the other 200 will just be false negatives. 90% specificity means if I take 90% of those that don't have the disease, so 90% of, in this case, 19,000, 17,100 will have a truly negative test, but there will be 1,900 false positives. So what's the problem with the test? Well, you see right away that your true positive rate is a lot worse than your false positive rate, such that if you take the positive predictive value, that's going this way, saying true positives over true positives plus false positives. So what we're saying here is if you have a positive test, because we don't know if people have the disease or not, if you have a positive test, how likely are you to have a truly positive test and have heart disease? It's 30%. It's a terrible test. False positive are your negative predictive value. It says how likely, if you have a negative test, are you to not have the disease? It's 98%. So folks for years said this is a great test. This was used just 10 years ago by every other country in Europe. They said it's great because it's got a good negative predictive value. When I say, hey, I could have told you with 95% certainty before you did the test that they weren't going to have disease, right? Because there's only a 5% prevalence. So it's not a great test at ruling it out. It's not a good test in ruling it in. So it's a terrible test. We shouldn't be doing it. And I'm happy to say there's only 3 countries that are holding out over there. I've convinced all the other ones in Europe to stop doing stress tests on everybody, whether you need it or not. This is called Bayesian theory, right? We've learned this in school. If you have a low pre-test probability, so if you're a young, otherwise healthy person, like most of us on the call, and you have a positive test, you still have a very low post-test probability, right? That's your 30% positive predictive value. However, if you told me, hey, my neighbor smokes, he has high blood pressure, high cholesterol, and diabetes, and every time he comes over to my house from his house, he starts getting chest pain walking up the driveway. Well, I don't need to do a stress test on that guy. I think I know what's going on, right? He has such a high pre-test probability that even with a negative test, his post-test probability is really high. So this makes total sense, right? But we're the United States military. We had to prove it, right? So guess what? We took all those folks that had that positive test and we stuck them in the cath lab and we did a heart catheterization on every one of them. So this is the study done a long time ago, 903 aviators. We did those stress tests. We took them to the cath lab. Average age was 44 years old. We followed these folks for 12 years and looked at that sensitivity and specificity. And then we looked at the event rates at 2 and 5 years. And look what we found. Positive predictive value, 16%. Positive treadmill, guess what? 16% chance you actually have disease. In fact, if we added thallium, so this is a nuclear tracer, this is back before technetium, thallium, you still only had a 21% likelihood of having heart disease, right? So it's a very terrible test. But then we did something else called fluoroscopy. In that old building I showed you, there used to be a little cath lab, believe it or not. And so there at Brooks, they would go in the cath lab. And even as early as the 80s, they would step on fluoro and they would see calcium. And if they saw calcium, they said, hey, there's calcium in that coronary, and they'd mark it down as a positive fluoroscopy. Before calcium scores, that's what they said. And we found out that this fluoroscopy seemed to work better than the treadmill or the thallium. Calcium in coronary arteries is probably bad. And it's funny because I kind of poo-pooed this in the literature, and this actually didn't get published, what I was told the first time we tried to do it. But then if we want to look at actual event rates, so we said, oh, stress test isn't good, but what about event rates? Maybe they do have some disease we're not seeing. Nope, look right here. If you do a treadmill and it's positive, it was a 0.5% risk of death, MI, or revascularization. And if it was normal, up is a 0.5. So all this told us was our prevalence was about 0.5%. It's a worthless test. You should not be doing stress tests in asymptomatic folks looking for coronary disease. But look at this. This stinking calcium shows up again. If you got calcium in your coronary arteries, it's 1.3%. And why is that a huge deal? For us in the aerospace community, that's a huge deal because that's a 1% per year risk, such that if you got calcium in your coronary arteries, you're disqualified and can never fly again. So it's a big deal. Again, not published because no one believed in calcium at that time. Here's just to remind you of what coronary disease looks like. So this is your LAD coming down your heart. Here's a bunch of crap in your coronary arteries that is going to eventually kill you, right? This is what we want to look at. This is what we want to find, but we want to find it non-invasively. I can stick a catheter in there and do this on an invasive angiogram. I can stick dye in there and I can see these blockages. If you have a blockage like this, that's cool. I like these high-grade hemodynamically significant blockages. Why? Because when you walk up your driveway, you're going to get chest pain. So if you have a slow progression of this, where you have a narrowed artery, when you go to exert yourself, you're going to exceed the demand of this vessel because it's blocked, right? So that's angina. We love that as cardiologists. We can fix that. This is what we don't like. We don't like this 50% stenosis, this vulnerable plaque that at any moment can rupture and have that big heart attack. Your body doesn't like it either. So what do you think your body does? Well, it lays down a little calcium on that. Well, that's really cool, because if it lays down a little calcium on that, all these little non-obstructive plaques with calcium, we can look up at on a calcium score. Otherwise, we have to do what's called a luminogram or an angiogram. I got to put dye in there. So that's what we used to do. Like I said, in the Air Force, we did that in all these folks. We saw that this fluoroscopy, again, this is pretty much a marker of calcium. Positive, you went over 1.8% per year risk. Again, this is per year risk of death, MI, or revascularization. Then we thought, oh, max lesion, if you have a 50% stenosis, you can't fly because you have a 2% risk per year risk of death, MI, or revascularization. So that's what we were using. But then we thought, what if they don't have a 50%? What if they got that 40% lesion that could bust at any moment? What if they got two of those? We got two 40% lesions. Are we going to say that's not 50% and let them fly? So a lot of smart people sat down and came up with something called this aggregate stenosis. The aggregate stenosis says you simply add up the disease. So if you got a 40% stenosis and another 40%, that's an 80% aggregate, right? You got a 30, and another 30, that's a 90% aggregate. When you do that, we get this nice distribution, whereas if it's less than 50, you got a 0.6% risk per year of death, MI, revascularization. Here, 50 to 120, you go up to just over 1%. If you go over 120, you got 3%. So isn't that cool? So that's something we can use. We'll call that mild, moderate, and severe. And since we did this on a bunch of people for no good reason, we disqualified a lot of folks, right? So when you disqualify a lot of folks, especially who's going to have heart disease? It's going to be old guys that fly airplanes. Who did we disqualify? Generals. We disqualified tons of generals. We disqualified tons of colonels. What happens when you disqualify a bunch of tons of colonels and generals? They say, first thing, stop doing that. No more screening. No more screening. Stop that. And then they said, you got to let us fly. So then we did this to say, hey, I think you probably can fly. Hey, if you're mild, what we'll do is we'll say, hey, we'll let you fly. Unrestricted, if you're mild, we'll let you fly. If you're 50 to 120, if you're in this middle area, we'll let you fly, but we don't want you flying high performance. We don't want you flying by yourself. So this would be with another qualified pilot, non-high performance. And these folks, that's too much disease. If it's something you can fix it, and we'll talk later. If you can't fix it, these folks simply cannot fly. So you could have a non-obstructive blockage, but if you got enough of them, this is just pure data that shows that's not good, right? But what's really cool about this is this was found on an angiogram. And I love doing caths. I did one yesterday. I did one Monday. I'll cath anybody here. You come on down, we'll cath you. But folks don't like caths, right? It's a little invasive. But this calcium score is a lot easier. My mom calls me up one day and she said, son, there is a big old semi truck pulled in the church parking lot. And they're doing something called calcium scores. They're $100. And I said, that's a steal, mama. Go get yourself a calcium score. Calcium scores can be done anywhere. What's great about calcium scores, they're not owned by Philips, GE, Magnavox, Siemens. No one owns calcium scores. It's Agustin units. No one owns it. It's great. It's a relatively inexpensive exam to get. And it's a marker of coronary artery disease, right? This is just an article that was done way back in 2007 that said, hey, your calcium score, if it hits 10, and there's data now saying even below 10, any calcium is bad. But if you hit 10 calcium score, your death, MI, revascularization risk is 1.1%. Look, goes 100 to 400, it's 1.1, goes in this 1 to 3% range. If it's over 400, 3% per year risk, death, MI, revascularization. You're all probably sitting there going, wait, I've seen those numbers before. I've seen them somewhere. This is all with the normal stress test, by the way. Because remember I said stress tests aren't good if you don't have disease? Well, if you got calcium, you got disease. So a great test after a calcium score is a stress test. Then you've increased that pre-test probability to a 50-50, right? So that makes it a good test. But let's go back to this. They're looking at this. It's calcium scores. Pretty cool. This is what I just told you about my angiography. This is me sticking a needle. It used to be in the groin. Now I've moved to here. People like the ones in the wrist. It's a little harder, but it's people moving to the wrist, right? We do angiograms through the wrist a lot now. And what do? This is what I showed you. Minimal coronary disease. We called moderate. We called it severe based on that aggregate stenosis. But look at this. Here's the calcium score. The calcium score, 10 to 100, it was 0.5 to 1% risk per year. That's exactly what I showed on my invasive angiogram. This 100 to 400, 1 to 2%, that's exactly what I showed on my angiogram. And then if you go above 400, exactly what I showed on my angiogram. So look at this. We now have a way for me to cath everybody without having to cath everybody. Calcium scores are a wonderful way to look for cardiovascular disease, specifically coronary disease. So just again, this is a summation of all the angiographic visible lesions, and it correlates very well. So it's a surrogate. Again, we're not seeing the inside of the arteries, we're just seeing calcium. But if you've got calcified plaque, it came from non-calcified plaque. The non-calcified plaque is the stuff we're trying to prevent. So calcium is very good idea. Here's the problem though. Can I do calcium scores in everybody? No. Why? Because you think I got a lot of people out of in trouble when I started doing stress tests in everybody. It's going to be even worse in calcium scores because everybody's got some degree of calcium in their coronary arteries. So I can't just go around and do calcium scores in everybody in the military and all my pilots. But what can I do? I can do a risk score. You do a risk score. If that risk score is low, then you got to do nothing. But when you come in, and every guideline shows us now, if you're in this intermediate risk, and you're in that intermediate risk, this is a Framingham risk score example here, and you have a negative calcium score, that's great. That's great news. If you have a negative calcium score, then you are free and clear, and you're doing pretty darn well. Control your risk factors. You probably don't have a significant amount of coronary disease, or at least nothing that's going to make you fall out of the sky for my aircrew. This right here, you get this 16 to 20%. That's again based on Framingham risk score. Even if you triple your risk, I just showed you my risk is only about 0.2%. So if I triple it, they're still setting at 0.6% risk per year. So again, even if they're in this intermediate upwards to 20%, if that calcium score comes back 0, I feel really good about it. So that's what we recommend. I don't care which risk score you use. It really doesn't matter. You can use any risk score. If you use those risk scores, you can use risk factors, whatever you do. If you're in that low risk, you're low. But if you're in that intermediate or high risk, do a calcium score. That'll put you into your proper risk stratification, and it'll tell us what to do next. This is a class 1 indication, which means this is how I explain class 1 indications to my my European colleagues. If you don't do it, you're going to get sued. All right. Class 3 indications are if you do it, you're going to get sued. But class 1s are if you don't do it, you'll get sued. So you should be doing global risk scores on everybody. All right. It is reasonable to do a calcium score if your risk is above 10%. Okay. That's a level of evidence B. It's a class 2A indication. You look right here, exercise stress test, you can start thinking about doing again, but the CAC is better. And in the latest guidelines that came out in 2019, they actually say that that calcium score is beyond the best thing to be doing in all of our aircrew. So what do I propose as a great cardiovascular screening algorithm? All aircrew age 40 and up, because all these risk scores are only really validated in that age. None of these yet. But if you do that and you put in a risk score and it comes greater than 7.5% risk. Now you say, why not 10? Well, because 10, I busted 1% per year, right? So just make it a little less than that. So let's make it 7.5. Even as low as 6, I think is reasonable. If you're in that intermediate risk, then let's do that calcium score. If that calcium score is 0, nothing else to do. If it's in that intermediate range, then do something else. Do a stress test. Do some stress tests with imaging. And if that's negative, you're still gonna need a waiver because you got calcium, right? But if it's otherwise negative, you can fly whatever you want. If you get up here in the 400 range or higher, we need to get a better look at it. And that's where we recommend going straight to cardiac catheterization. And nowadays we've got CT angiography. So a lot of times they'll do the calcium score. It comes back higher than 400. They'll put an IV in you, stick you right back in there and get that CT angio for me. Kind of breaks my heart. I'd rather do the cath myself, but they do very well. And then everything has to be verified though with an invasive cath. And then look at this, lo and behold, if you have heart disease, we're gonna let you fly. So we changed the policy, right? We changed the policy. So you can screen. Before, screening was wrong because we just disqualified you. Now we screen, we find it, we fix it, we let you fly. So that's why we need to be screening. So what is the current screening policy? It's shown right here. You say, wait, there's nothing, there is nothing there. There is no screening policy. It's the same screening policy for the FAA. There is no screening policy in the United States Air Force or in the FAA. You say, how do you get away with that? Well, we get away with that because of this, because every guideline, like I just showed you, tells you to do a screening in everybody. Now, I would love to make it a policy. Joe will tell you it's been kind of like the focus of my life for the last few years. And I've got 3 years left to do this. And they were dumb and promoted me. So now I've even got more power to beg to get this passed. And this is why I'm talking to you all, because I think you are doing the right thing. You are saying, hey, calcium scores are a good idea. Calcium scores are good if you're not low risk. If you're high risk, you got to fix that. Low risk, you got to, we don't care. What we want is right here, right? This risk in the middle, get that calcium score. If that calcium score comes out over 100, then you need to do one of two things. In my world, I need to do some kind of stress test. I need to do something to make sure that's not hemodynamically significant. I got to make sure that that total burden disease is not too high. For everybody else, though, you can just treat it appropriately. And the best way to treat that, as we know right now, is statin therapy. So statins and aspirin in the right population. Every one of my folks that gets diagnosed with disease has to go on a statin. So if you're a pilot and you're diagnosed with coronary disease, you have to go on a statin. You also are recommended to go on an aspirin. Again, in select situations, you have to weigh the risk and benefits of aspirin. But the statin is definitely somewhat of a no-brainer these days. And then the last thing I'll leave you, or last thing on this topic, is a new risk score. So this is a great risk score that I got to, I came in a little too late. They were already developing this, but they asked my opinion, and I thought it was a great idea. This is the NASA's Astro-CHARM score. So Astro-CHARM came out based on data from MESA. You may have heard of MESA combined risk score. It has a calcium score in the MESA score, the Dallas Heart Study, and then the Prospective Army Coronary Calcium Project, which you've probably heard of. So they took the data from all those and came up with this Astro-CHARM score. And what's cool about this is it takes your risk score, kind of like a Framingham. It includes family history, which is very important, especially in our young folks. And it also includes that calcium score. MESA has a similar score. The only thing about MESA is it's validated in ages 45 and up. This goes down to 40. All right. And they use the MESA data to come up with the Astro-CHARM score. So it's actually a lot larger cohort here. So this is what we recommend now. So if I could go back and change that policy, which I'm going to do, and I think I already told Dr. Bommer, I did this last Friday. I actually submitted it to include this as the risk score. So after you get that risk score, you're going to, and you get the calcium score if it's indicated, then you're going to go into this before you go on to the exercise stress test or imaging stress test. So this is a great thing to use. Again, the MESA one is 45 and up. This is 40, includes all those. And I think it does a great job at telling you who needs to get further evaluated. And then it puts you back in that 10% risk based on 10%. So to end, now we're going to have some fun. Okay, this is us. All right, this is us. This is us. These are folks just like us. I'll tell you, I've had 6 people who passed their PT test or a marathon, or one guy did the Ironman, and made it through. I think he was scored in the top 10 and then had a sudden cardiac death or a non-STEMI or STEMI right there within hours of that exertion. All of them had revascularized heart disease, all got it fixed, and all of them lived. I've had a lot of folks come to me and say, listen, something's wrong with me. I just went and ran a mile and it took me 8 minutes. And I'm like, dude, well, that's better than me. And like, no, something's wrong. Something's wrong. I run a mile in 6 minutes. I got a 90 on my PT test. I've always got 100. And I'm like, there's nothing wrong with you. I put them on a treadmill, huge ST depressions, throw them in the cath lab, and they've got a 99% LAD lesion. So why did these people get disease? That's what I want to know, because these people look just like me and you. Why are we getting heart disease at young ages? and I found a couple little things. First thing, BMI of 28. You say 20, that's not bad. Well, I'll tell you, this isn't really, there's most of these people are right at 25, 20, and then there's ones higher. So it's pushing it up a little bit, but most of them are overweight. So they say, I read just yesterday, I read that it said 1%, if we can shave 1% off of the national body mass index average, over 2 million cases of diabetes would be prevented. 1.4 million cases of heart disease would be prevented. 127,000 cancers. Read that last night. So that's important. So get your BMI 25 or less. Body fat is better than BMI. We do a lot of body fat measurements now because we have people that are coming in all muscle, and military likes muscle, right? So we get some muscular people. We'll do a body fat measurement on those folks. But that's not the problem with most Americans. So BMI, try to get that 25 or less. They do better and follow up. Average HDL is 34. That's below 40. That's not terrible. I know some of you are probably saying that's not too bad, but it is pretty bad for our folks because they exercise. So one of the best ways to get HDL up is to exercise. These folks exercise, and they still have an HDL, low HDL. We want that above 40, above 50 is perfect. Fasting glucose. They all have this little impaired fasting glucose. Again, in people who exercise a lot, that's odd, something to look at. LDL average 136. Most places still call 130 to 160 normal. We all know that a good LDL is less than 100. When you came out of mommy, when you're born, it was 40, right? So we've screwed it up from there. Triglyceride average 140. Again, not terrible. Sometimes it wouldn't even come out positive, but that's a little higher than you want it to be. Systolic blood pressure was just over normal. And then family history is more common. However, these folks, a lot of them do exercise. At least they take their PT test or say they do, right? But if you had none of these risk factors, you did pretty darn good. But here's one thing that was very odd, and it'll be the fun part of what we talk about tonight. These people don't drink alcohol and they don't drink coffee. You say, what? I'm like, yes, 25% of Americans drink alcohol every night. I didn't know that. Or I'm sorry, 15% of Americans drink alcohol every night. 25% of Air Force people drink alcohol every night. These folks, it was only 8%. And this is moderate alcohol consumption. Again, this is 1 to 2 alcoholic beverages a night at most. If you go over that, bad, but a little bit may be okay for you. And also coffee. 62% of Americans drink coffee, while only 20% of my folks with cardiovascular disease drink coffee. Some of them exercise too much, and some of them don't exercise enough. So I looked into this more. We're actually and this is the hardest IRB study I've ever had to try to get through, to try to prove the benefits of alcohol and coffee in military. It's not good. It's usually the opposite of what they want to see. But that's what we're looking at right now, because I saw those folks that did have a little alcohol and a little coffee. They didn't get revascularized again. After that first time, they did great. And so proven benefits of both of these, which I'll go over in a second. Diet and exercise also. If you have exercise a lot and you still have a low HDL, it's probably genetic, right? But there is something called over-exercising. And it seems like there was a little bit of a curve there where you actually got increased risk of problems if you got too much exercise. So there's a right amount of exercise. Low HDL raised by diet and exercise has always been shown to be preventive. And every risk score you look at, HDL is always included. However, every study they've ever done to pharmacologically raise HDL has been negative. I remember talking to Steve Nissen, who's a very prominent cardiologist up at Cleveland Clinic, and he was sitting there saying, Eddie, will you just let go of the HDL thing? And I was like, boss, I can't let go of it because every single person I have under age 30 that's had a heart attack, every single air crew member has a low HDL. There's something there. And where to raise that up is actually more vigorous exercise. So I had these marathon runners with these HDLs in the 40s and 30s. And then I all of a sudden have them, 30s. One guy was 28. He had an HDL of 28. I said, you got to stop doing this marathon. Stop running forever. Just do that high intensity, short duration. And we raised his HDL up in the 50s with just high intensity, short duration exercise, which he hates, by the way. So, and I hate long distance running. So proven exercise, it decreases diabetes. We know that. Heart disease, heart failure. It works better than a statin if you control for it. So if you put someone on a statin versus an exercise program with proven that you can prove they're actually exercising, they were equivalent. There was no statistically significant difference. However, there is an inflammatory response such that if you actually had a heart attack in the past, the statin did do better than exercise, which tells me it's doing a lot more, and we all know this, than lowering your cholesterol. There's something else that it does. Beta blocker, though, exercise better than beta blocker. What I love it is if you exercise, you can't use the beta blocker, right? Heart failure, better than a beta blocker, better than diuretics. for stroke, it's better than an anticoagulant and an antiplatelet. All right. There is a risk of too much exercise. So I say if you go over, if there's a 1 in 100,000 chance of you having a heart attack, if you are a marathon runner, triathletes have a 1 in 40,000 chance. Triathlons are very hard on your body. Maybe an increased risk, but it's a heck of a lot better than the dude, watching TV, playing video games, right? So if you're going to pick a hobby, okay, run marathons, but just know it's not very good for you. I saw a guy today, one of my patients who's just had revascularization last year. He came up for his follow-up visit. He's like, dude, I'm back to running marathons. I was like, no marathons. Just how about a 5K? I'll let you do a 5K a day if you want, but no marathons. Athlete's heart. As we know, if you do a lot of pumping, a lot of iron, we have a lot of iron pumpers in the Air Force. You get that thick heart. If you run a lot, you get that real thin heart that's really big. So again, we don't want that. For most Americans, that's not an issue. But for everybody, if you limit it to 60 minutes, not going over 60 minutes, you'll be just fine. All right. And no guideline tells for you to go over 60 minutes a time. Nothing does that. The American Heart Association, American College of Cardiology, none of them say that. In fact, they say shoot for a vigorous exercise is 80% of your max heart rate. If you're 50 years old, that's only in the 130s. If you're 60s, that's 120s, 130s. If so you don't have to get it that high just to be vigorous. I do recommend vigorous over the moderate, which again, if you're 60 years old, they consider moderate exercise in the 120s. I get 120s just walking in the snow into work every day. So got to push it just a little bit. This is a great graphic here, just showing if you take normal subjects, right? And you take normal subjects that can't do 5 minutes of exercise, right? And you follow them over 10 to 15 years, look at their survival. It's about 50%. But if you take someone who has terrible heart disease and they can go 8 minutes, look at their 10-year rate. They're more likely to be alive in 10 years than the person that can't exercise. Look over here. This is just looking at your relative risk of death here on the y-axis. You can say for folks that can't do 6 minutes of exercise, that's going up a flight of stairs with a bag of groceries. If you can't do that, you're more likely to die than the person who has cardiovascular disease. And in fact, if you have cardiovascular disease and you can go 13 minutes, look at this, you're just as likely to die with somebody that doesn't have heart disease. So exercise is so very, very important. And that's why I like this after your calcium score comes back abnormal, because this kind of tells my folks, my air crew, say, this is where you're at, And the other thing that's great about air crews, you can sit there and tell them, hey, F-16 pilot can go 10 minutes and you're F-22 pilot. Come on, man. So it's great. You can put them up against each other. So it's a great way. It works well in the military. This is the CAS registry. Go back to the CAS. This is the study that came out in the 1980s that said bypass is good for you. If you go back in those studies and you look at people, those folks that could actually get on that treadmill and do 10 minutes, it didn't matter if you had 3 vessel disease or not. You did just as well with or without bypass. It's amazing, right? So exercise is very important. American Heart Association says 30 minutes most days of the week. It'll decrease your risk by 50% of any kind of heart attack. Don't do endurance stuff, like I said. The higher intensity exercise, interval training is the best. There's something called super fast twitch fibers. I bet there's some people in America that's never twitched their super fast twitch fibers, right? This you only get when you really push your heart up to above 80, 85% of your max heart rate. That will increase your growth hormone and increases testosterone. So you don't got to replace it if you do a little exercise, and it's associated with making you live longer. All right. I say whenever you push your heart rate above 85%, you're having heart attack practice. Really, most of us cardiologists on the line will tell you, you're going to go, most of the time I see people die, they go into a VTAC, then they go into VFib and they die. That VTAC is usually going about 200, maybe up to 250 beats per minute. If your heart was at 180 and 190 last week because you were exercising, then when your heart hits 200, you're not going to die. So I think I saved it for the last slide. I'll give you a little hint. I can't prevent heart disease, but I can make you not die from it. And this is one of the ways. You got to do your heart attack practice. So every once in a while, I see people at the gym. They'll see me at the gym. They go, "Oh, you're doing our heart attack practice." So if anything, do your heart attack practice, and then also some kind of strength training. You want to do strength training at least once a week. The latest guideline just came out, said twice a week. I think that's a great idea. Do whatever you want. Pick 5, 10 machines. Go do 3 sets. So this is what I recommend. This is what I do. This is what I recommend to all my patients. Again, 3 days a week, do some kind of cardio, do some strength training a couple days a week. I used to do Monday, Wednesday, Friday, Tuesday, Thursday. Now I've switched it to 2 days a week. My older patients like 2 days a week. So that's what I recommend. Rest on Saturday and Sunday. Take a day off. How about alcohol? Decreases CRP, increases HDL. It does promote oxidation of test tube. However, it's been shown that in moderation, that does not happen. Minimal blood pressure effect. What's the optimal amount? You can only have 1 to 2. If you go over 2 servings of alcohol per day, over 14 servings of alcohol a week, you have increased risk of everything. I'm talking pancreatic cancer. We're talking every kind of cancer. We're talking heart failure, everything. So if you are one of those folks that can't limit yourself to 1 to 2 drinks, please do not do alcohol. I rarely recommend this for folks, but man, there was one study where they gave people the flu shot, the people who, or versus 1 beverage a night, and the people that got the 1 beverage a night had less flu. That'd be very unpopular right now in COVID, or have everybody drinking to prevent COVID. But I'm just saying it works, and it's worked in my patients pretty darn well. And I do see a very much a decrease. Again, you've got to limit it though. And we can't recommend it officially because of the abuse potential. Coffee though, I definitely recommend coffee. 11 to 50% decreased diabetes, that's well known. There's been a lot of studies. There's a decrease in Parkinson's, cirrhosis, heart failure, cardiovascular disease, Alzheimer's, even prostate cancer. It's very low calorie. There's no calories unless you add stuff to it really. It's actually associated with some decreased fertility and increased osteoporosis in females. It takes 1 tablespoon of milk to negate that. So I say have 1 tablespoon of milk, heck, stick it in your coffee, all right? So coffee has been shown to be helpful. Both coffee and alcohol though, with any tobacco use, is completely negates the effect. Coffee has a 15% risk reduction, so coffee has also been shown to be good for you. And then finally, the diet. What I see with diet is typically Americans just eat too much. It's not even, there's been a lot of studies lately saying, different kinds of diets. We know the lower carbs is better, it decreases your cholesterol, but definitely the diet we see and that works best is the diet you can stick to, and the diet that keeps your BMI or your weight controlled. And that's been shown over and over again. So when people tell me I need to lose weight, I say skip a meal. Only do 3 meals a day. You don't do smaller meals like a lot of folks say, 3 meals a day, and just eat a little bit less, or skip a meal is fine. Alternate day fasting works well. Over in the UK, my counterpart over there, he's a big alternate day faster. You need about 500 calories a day if you're going to exercise. If you're not going to exercise, then you can actually do an alternate day fast, been shown to be very safe. However, if you are exercising, please get that 500 calories, because that's about what you're going to burn with your exercise. But if you decrease it by 500 because you want to lose weight, and you continue eating normally without a fast, you will lose about 2 pounds a week. So Bagram body, I'll leave you with this. I went to Bagram for 6 months. So I said, hey, it was over 6 months. Went to Bagram, got stationed there in Afghanistan. I said, hey, I'm gonna do a grand rounds. So we did a grand rounds, took all the folks in the hospital, all the technicians, everybody. And I said, hey, let's try this. Let's try doing my little cardio 20 to 60 minutes a day. You got to hit 85% of your max heart rate. You've got to do strength training. You got to do that 2 days a week. And you can't go over. You can't have alcohol, but you can't have coffee. So I said, you got to drink your coffee every day. And then I met with folks if they wanted to. We did this 500 calorie decrease to get their weight down. I had 30 people sign up for it. We did it over 16 weeks. Bose was nice enough to give me some headphones to the people that did it. So whether you lost weight or anything, if you just helped me out, you got these headphones. And so it was so nice of them. And average had 30 people. Most people lost about 2 inches off their waist. Body fat went down about 5%. I had one guy that had a body fat at 35%, went down to 15%, just based on this. And we did that via the calipers at the gym there. HDL, I only checked those in the docs, but that went up about 7 points on average. The physique was the biggest contributor. People just looked better. There's a lot of people still doing this. So here's my un-Air Force approved slide, but that dude came in with it. We had an anesthesiologist come in with a BMI or a 35% body fat, and he left at 15. I saw his wife a few years later. She said, send him back to Afghanistan. So this was the biggest contributor. It's funny because people were sending me pictures, and I was afraid I was going to get kicked out of Afghanistan because of the pictures people were sending me. But again, that's why the strength training is also important. So in summary, do a risk score. So everybody here, I say, this is why I call it Heroes with Heart Disease. I say, listen, y'all can be, you can do this. Anybody can do this, even though it's, we do it in our air crew. Do a risk score. If you're not low risk, do that calcium score. If that calcium score comes back, anything less than 0, do one of those new enhanced scores. There's a Mesa one. I like the Astro Charm one also. Stick it in there, and then get put on a statin. Consider aspirin if you're high enough risk, but then do the diet we talked about. Do the higher intensity, lower duration exercise. Have a couple cups of coffee. Have a glass of wine, and life is good. Last thing I'll leave you with, though, is stress. I will say, when I looked at my 30-year-olds and my 40-year-olds, young folks getting heart disease, we found a lot of stress, deployment stress, divorce stress, financial stress. That was definitely as big a factor as any other risk factor. And so I looked it up. Joy, people who are just happy because they're happy, right? They choose to be happy. That inner joy, those people live longer. People with integrity, people that do the right thing when no one's watching. They've done studies. Those people live longer. Grace is kind of what we call in the Air Force, we say service before self. But grace is just that thing where you do something for somebody expecting nothing in return. Folks that do that live longer. And we're talking 50% reductions, as good as anything else I've told you tonight. So go grab a cup of coffee, glass of wine. We'll listen to Dr. Bommer while I have my glass of wine, because here you are in my house, right? And I thank you so much for listening to me. So can I ensure you ever get heart disease? No, I can't do that, but I can make you not die from it. All right. So here is the bell curve of life, right? Get your weight right, have some coffee, have a glass of wine, exercise every day, and live forever, right? A life worth living. Thank you so much for having me. I appreciate it so much. Like I said, it's a great honor to be here, and it's fun. It's a fun passion of mine. So any questions, or we can save the questions? I think I only left about 3 minutes for questions.
Oh, I think we can do a couple of questions. Do we have any? That was certainly I was going to say that was like a 5K review of risk factors and reduction, and certainly appreciate your experience in treating your large population, and that database is huge. So if we have any questions, if not, I'm going to make Joe Sky do push-ups so he can get his heart rate up for the next talk.
I just have one comment and question. This is Nerali Borahai joining late, and thank you, Dr. Davenport. That was great. I'm a stroke neurologist myself, so even though all of your outcomes are on heart disease, I know you're helping stroke too. But my question is kind of for everyone, and specifically for you. You know, do a calculator, but technology can help make this calculation easy. All the data is in the chart. How is the space that you work in leveraging technology to make it easier for us to do the right thing?
That's a great question. Right now, I'm just trying to get all the data to do the analysis, like we were talking about. But that's a great point. We do have an electronic medical record. Supposedly, the VA invented it, right? But it's not very user friendly, I would say. But that is a great idea. I feel stupid to say I haven't thought of it. Joe, you should have thought of that. We should be doing this.
So I'm actually.
That's why they hired me.
They got all the data, and we're in the Air
on
Force.
the
You
panel
can order
that is
people
trying
to
come up with
exercise.
that right now, and we're going to be in San Diego installing the latest medical center for our medical record system. We're working on it. We've obviously had great right care presentations, I believe, at the Stanford group with some of the really impressive things that are available in the civilian world. So, Dr. Davenport, we have a question in the Q&A box here. And first of all, someone also said that you gave a great, informative and motivating talk, and I concur. I really appreciate the great things. I learned things that have happened since I've left, and it was wonderful. So what about using fractional flow reserve based on CT or computed tomography images?
Yeah, it's funny, when I first started this job in 2009, way back at Brook City Base, I started working with this Ed Nickel over there in the UK, and he was big in CT, and I just poo-pooed CT mainly because I think I like to do a lot of cath, right? But CT back then was a huge dose of radiation. CT back then was a huge dose of contrast, and I always prided myself as being the guy that could get in and out of the cath lab in 10 minutes or less with 30 cc's of dye. You know, and I could do a cath that looks better and is better than a CT. However, CT's come a long way. The radiation's gone way down. And one thing we have been finding is all of us cardiologists, where we sit there and look at a lesion, we say that's 50% or that's 60 or that's 70. I found out that's not too good when I'm seeing these things from all over the world. And so now I'm sitting there saying, hey, if that lesion, if you think it's 50%, if it looks like it's anything 50% or greater, I want you to FFR it invasively. And so I've gotten a lot of these, and we're doing a lot more CT angiography, and I'll accept CT angiography just like invasive CT. And so the FFR also, the first few FFRs I got, man, they were terrible. I was like, I don't know. But that has also come a huge, a big, long way. My colleague in Germany, Munich, Germany is Siemens. They're based out of there. So they're doing tons of CTA. They're doing tons of FFR CT. I do like it. I think it's a great idea. And if you see anything in there, like I say, even close to 50%, I love being able to look at that and look at the flow. So yes, I'm a believer now.
So, I mean, I think it's fair to say that it's a promising technology and modality, but it has not yet been correlated with aeromedical databases. Would that be a reasonable summary of the current state?
Absolutely. In fact, our CT angiography data is pretty low in total. And both the same thing with calcium score. I know you've contacted me many times over the last 9 years saying, Eddie, what are you doing with the calcium scores? And as you can see from my presentation, as hard as I push this, I still can't make it a policy. And that's what I'd like to see in the future, some kind of policy for calcium scoring. But for now, yeah, exactly what you said is right. I just simply don't have enough data. I just got a CT angiography here at Wright-Patterson. So again, I've been here for 8-9 years, and I've just now got my CT scanner that can do CTA. I will say down at Wilford Hall, if you get a calcium score and it comes back higher than 100, they do pull you out, put an IV in, and go right back for the CTA. So we're using it a lot more. I'm getting the data, but I would say right now I probably have 70 scans. I just don't have enough, but it will get there, and it'll be a good database.
And
Hi, Dr. Davenport.
I think for a historical perspective for everyone listening, Eddie, unless you have more information, what our mentor Bill Cryer taught us was the fluoroscopy at Brooks was roughly equivalent to 100 to 150, depending on which of the operators was viewing the fluoroscopy that day. And so there was a transition that you took the charge on with transitioning over to using the Augustin scores with CT. And as we look at the new things with CT angiography and FFR, there's going to continue the need and availability of data amongst the aeromedical medical agencies of the world. And
we kind of lost you there, but yes, I everything you said is absolutely true, and I agree. And now with this new electronic medical record that the Air Force is coming out with, based on that other great question we had, we can find these by looking through our database through the computer and some AI technology. That would be really cool too, even outside of aircrew.
If we have a moment to address the slide that you showed very briefly on the sudden cardiac death, I don't know whether you can hop back to that and do a little bit of elaboration. We don't often talk about that, maybe because people don't think there's much we can do about it. But maybe there is.
Yeah, I'm not sure which slide. I'll look through there, but and I didn't show you the actual numbers of the sudden cardiac deaths we've had, which is amazing.
Before you answer this question, I should tell you one of Hattie's biases is that the Right Care organization has been the leading promoter of portable calcium scoring in Northern California, and Hattie is a huge advocate. So this is a teed up question for calcium scoring.
Yeah, well
I wasn't thinking I had that much time, but it's just that with my family having the surprising scenario of very low risk scores, but bad family history and high calcium scores, it's been very important knowledge for our family, and many of the people in the Right Care Initiative who've gotten scanned, they've gotten the heart CT, and we've had quite a few lives saved, I think, just in the few years we've known about it.
Yeah, that sounds awesome. I don't know which slide it was. If it's just the one showing that the sudden cardiac death is like the #1 presenting symptom, yeah, that's definitely that's definitely the case. I don't have any correlations specifically with that in the calcium scoring, but it only goes to say that would definitely be the case. You'd prevent a lot of heart disease. In fact, I don't know. So one of the things I'm looking at is that Astro Charm score, because of the inability of some risk scores to help you out a lot. I guess that's a nice way to say it. Doing a calcium score in everybody. Should we just be doing a calcium score with a risk score? And maybe in my high performance pilots, maybe in my space, in the astronaut population, they all get calcium scores as part of their that Astro Charm risk. So in our highest high performance air crew, should we be just going to the calcium score to prevent not only that, but sudden cardiac, not only coronary disease, but the sudden cardiac death as a marker of that coronary disease would probably be a great idea. I do have that. I did push that. And then as Joe will tell you, if we want to make policy a little easier, hey, we want to now let this fly, like AFib. Joe will probably be surprised. We've got an F-16 and an F-22 pilot flying with AFib. We've got 2 astronauts flying with AFib. So that's something that was unheard of before, and we've gotten so much better. So we're changing that policy. That's easy to get that policy, believe it or not, is easy to get through. Hey, I want to do a calcium score on every high performance pilot. Oh, hell no, that's not going to get through, So that's the issue here. If you want to make stuff a little more strict, that is rough. Yeah, so any data you have, now we're friends, Hattie. So send me anything, anything you've got that shows that we can do it. That's what I need. That's the data I got to keep pushing to the Air Force. Joe sends me stuff all the time, and I just push it out there and say, listen, look at this. Let's do this. Thank you. And on the other folks, the lady on the AI, send me some data. Yeah, any of that stuff just helps us. As Joe could tell you, it's an uphill battle. But I always like to end with this. We say in the military, we have the world's greatest patients, and we do. We have the best patients in the world. My patients are my heroes. I remember being at one of these sports cardiology section meetings, and they're talking about the NFL and the NBA and the NCAA, and they're sitting there going, yeah, we have, our patients are heroes. I'm like, oh, that's crap. You're overpaid athletes. My patients are the heroes, and they deserve to be treated that way. And there is a certain echelon of the military that gets a lot of screening. All right, and there's a certain group that don't, and I think everybody should. And so again, now we're best buddies. Everybody here, just send me that. We'll get her done. And then your right care initiative will sprinkle over into the Air Force. But you've got an imposter.
Let's do a follow-up conversation, and possibly Bob Trine can get us together with Gunderson Healthcare. Nirali, are you with us to turn your video on and do the transition, or we'll have Joe?
I think Joe can go ahead because I'm on call and I'm getting
Another case. Thanks. Oh, okay, thank you, Nirali. Joe, you're on. Thank you, Dr. Davenport.
Thank you. Great presentation.
Thank you so much. Anytime. Next time I want to come out there, though. It's cold here.
Yes. Welcome.
So while we have Joe come back on the line to do the transition to our statewide chairman, I just want to welcome Joe back from Fresno. And Joe, you're muted and you may be having some technical issues. This is definitely a team sport that we are in here. And I know that, Joe, it's such a pleasure to have you back with us. So can you just say a couple minutes about your service in Fresno before you transition to Dr. Bommer?
Oh, sure. So everyone knows that in the end of December, California hit crisis levels in several metropolitan areas, including Central California, Los Angeles, the area in between Los Angeles and Palm Springs. And as has happened in several parts of the country, there's a model that I think was actually developed at the Mayo Clinic where hospitalists, family practice doctors, subspecialists could be used as augmentees or force extenders, as the military would call it, for the critical care docs. So for the last 6 weeks, I worked on a daily basis with pulmonary critical care, and I had patients assigned to me, but they were available as experts in COVID. And the hospital I was at had a normal capacity of somewhere around 400 patients. The ICU had a normal capacity of around 25 to 30. For much of the end of January, much of the middle to the end of January and into early February, we were at over 700 patients in the hospital, and we were at over 2.5 times that in the ICU. So we did that by expanding teams. 2 of the entire critical care teams were made up of subspecialists, and including military. And by working as teams, we were able to maximize the knowledge of the critical care docs, the pulmonary critical care docs. And we were able to, at no point in the county of Fresno did we ever have to turn away a patient that needed to be in the ICU. And we made it through it. So the model's out there, and it was an interesting experience. Glad to have completed it successfully. Don't ever want to do it again.
So we're really, really glad you're back. You made it through, and it was some sad stories I heard along the way. Maybe we can talk about that more at the end of the program. We have our statewide chairman, cardiologist Bill Bommer from UC Davis, former president of the California ACC, with us to talk about some progress being made in acute and post-acute COVID at the UC Davis world-class medical center in Sacramento. Bill, you're on.
Thank you, everyone, for joining us. Megan, can you turn over the share screen to me? And I will bring up the slide. And let me know when that is available.
You can share screen.
Have it? Let's see. Hang on. So can everyone see, let's say, the thing Joe Sky has been fighting for the last 2 months on the screen?
It's quite a nice graphic. Thanks, Bill.
Okay. We are here to talk about what is temporarily for the last year was the #1 killer in the United States and in many areas of the world. So unfortunately, COVID-19 got to mortalities that were as high or slightly higher than cardiovascular disease, which was our old #1 killer for that. This is what the virus looks like on the left, and you can see it is an extremely frail virus. Almost anything can kill this virus. It's got a very thin shell or envelope. If it dries out, it in fact dies. This virus is really, really weak. However, this virus can be very infectious. Why? Well, this virus cannot move by itself. It doesn't have any flagella or any wings, or cannot swim. It can't really get from one individual to another. It requires us humans to, one, put this virus in the air, to propel it over into someone else's vicinity, and that other individual to inhale it and get contact. And the contact has to be within microns of our susceptible cells for it to work. Very weak virus. It's destroyed by heat, by sunlight, by a number of detergents and surfactants, but yet it has been extremely effective in getting around the world and infecting, literally in the US, millions of individuals. And when you get the acute infection, it can affect many symptoms as seen here, from congestion and headache to diarrhea to productive cough and fever. On the right, you can see that it affects literally every organ and part of the body from head to toe. And although it affects all of these organs, it also can lead to a very serious outcome, which is death. And today or yesterday, we marked 500,000 deaths in the United States. So this is certainly an extremely severe infection that we are dealing with. So the infection is seen in two forms. It often affects the lungs initially. And what you see here on the top is the virus gets in with close contact to the macrophages and to the respiratory cells. And with that, it transfers into the cells and creates an infection in the cell, shown on the left. Later stages of the infection are associated with a inflammatory reaction and sometimes a cytokine storm. Both of those lead on the top to significant damage in the alveoli of the lungs, leading to often pneumonia as a primary presentation. On the bottom, the other serious infection that occurs with COVID-19 is cardiac involvement. And cardiac involvement is initially initiated by the interaction with the ACE2 receptor on cardiac cells and vascular cells, leading to significant inhibition of the renin-angiotensin system. Hypoxia can also lead to myocardial injury and ischemia. Cardiac microvascular damage damages the little blood vessels that feed all of our hearts and brains and the rest of our body, leading to significant problems. And the last is a systemic inflammatory response, often associated with cytokine storm, shown on the right, where we initiate an overwhelming and unstoppable inflammatory reaction that leads to actual damage to our cells. And sometimes this inflammatory response can injure our organs and tissues more than the actual first virus did when we had it. And lastly, we believe that microvascular thrombosis is a significant pathologic process in this. It is initiated by the virus, activated by neutrophils, leads to hypoxia, cytokines and complement. And many of our individuals are presenting with microvascular thrombosis in these patients. This thrombosis occurs in the vessels in the lungs, including pulmonary emboli and microvascular ischemia. It can occur in the heart with coronary arteries, leading to increases in cardiac enzymes like troponin, myocardial ischemia, heart attacks, and can lead to vascular obstructions from the thrombosis in multiple organs, all of which leads to damage to the particular organ. The acute infection is shown on the left, and what it is the acute infection is going to last up to 3 weeks or so. If it's mild, if it's severe, it can obviously leave you in the hospital beyond 3 weeks at that time. But many individuals recover from the acute infection within a 3-week period of time. Some of those individuals, however, progress from the left side of the screen to the right to what has been termed post-acute COVID-19, also termed long haulers and other terms. In these individuals, they have persistent symptoms much beyond the 3-week limit and organ dysfunction in these individuals. The organ dysfunction can be individual organs or a multi-system inflammatory syndrome, which affects multiple organs. And the post-acute COVID seen on the right does not necessarily go away. It lingers That's why it's been called long haulers. On this slide, you see on the left the symptoms of acute COVID in dark black. And you can see it presents, as we said, with fatigue, dyspnea, joint pain, cough, and other things shown in a relatively high prevalence of individuals. Up to 80% of individuals will have some of those symptoms. On the right in gray is the post-COVID follow-up in individuals. And you can see that there are still symptoms in the post-COVID follow-up. And in those individuals, it includes still fatigue and dyspnea, but a variety of other symptoms are persistent in these individuals. And if we look with the patients who continue with these post-COVID symptoms, you can see it's anywhere from 10 to 40% of these individuals, or 50%, will have a post-COVID syndrome. On the right, a recent study showed 143 patients in Italy. You can see a significant number of these individuals had persistent symptoms that were displayed, 40 or 50%. So we believe that post-acute COVID occurs in anywhere from 10 to 50% of individuals who survive their initial acute COVID infection. And the difference between acute and post-acute is shown here for the heart. Acute manifestations are cardiac injury, myocarditis, shock, and as I said, thromboembolic events. Post-acute, shown at the bottom, continues with myocardial inflammation, myocarditis, and we start to see myocardial fibrosis or scar, arrhythmias, and cardiomyopathies in these individuals. Unfortunately, the myocardial fibrosis and scar don't easily go away, so we don't know how long post-acute cardiac involvement is going to last. The reason for it is the virus has been shown to actively get inside the cells of the heart through the ACE2 receptor and create actual viral damage, as shown on the top, followed by an intense immunoresponse with cytokine storm and lymphocytes entering at the same time. So the heart, unfortunately, succumbs to both direct infection by the virons as well as indirect damage from the inflammatory overreaction, leading to necrosis and shock, and the risk that we have of scarring and myocarditis is significant for post-COVID. The outcomes in individuals can be demonstrated first in a German study where they showed that cardiac involvement after recovery, so these are individuals who had mild to moderate COVID acutely and then recovered from it, and they saw evidence of cardiac inflammation and involvement on cardiac imaging in 60 to 70% of individuals. So this is not a disease where you recover and can walk out and be entirely well. As many as 50 or 60% of people will carry out with them residual problems related to that initial COVID infection for that. And we don't know how long these symptoms and these signs will last. We know that they not only affect older individuals at high risk of COVID, they can affect individuals who are seemingly competitive athletes at the prime of their health, where this study out of Ohio, where Eddie is from, showed that individuals up to 46% of people who were athletes got screened, and when they came back to their active athletic training, were found to have evidence of myocarditis or prior myocardial injury. So this is significant even in the young and healthy individuals, and we really don't know what these residual changes shown on cardiac imaging will in fact influence them over the years. For pulmonary consequences, acute is usually associated with pneumonia or ARDS and respiratory failure. Post-acute continues with signs and symptoms of perhaps restrictive lung disease, where they have both reduced respiratory strength, they can't take a deep breath, and because of fibrosis, they cannot stretch out their lungs to take a full intake of air, and they have a reduced lung capacity with a reduced DLCO or CO2 perfusion. And in those individuals, we feel that it is probably residual interstitial thickening and fibrosis that has occurred. Now remember, this is in individuals who've already recovered from the acute phase of the disease, but they may now be left with persistent, and we don't know how long lasting, evidence of fibrosis and other things that potentially are going to be very difficult to go away if they go away at all. And lastly, neurologic post-acute COVID leads to problems. You've heard people say of a persistent fog, brain fog that they have, where they can't think straight. There are other imaging abnormalities that are seen here on the right, which are significant. And if you have major imaging abnormalities like this, including thrombosis and ischemia in the brain, it's not known how long it will take for this to recover, if it in fact can fully recover in these individuals. So COVID is not something that when it first came out, say, hey, everybody gets it, we'll get herd immunity, it'll go away. But unfortunately, the infection and post-acute infection is going to leave us with a significant, if not severe, morbidity that may last in these individuals for a long, long time. Individuals who have renal involvement with the original infection and acute COVID, which is seen in a significant number of individuals who are hospitalized, can persist with this renal involvement. Remember, the kidneys are really vascular tissue, and this, in fact, affects the vessels significantly, many with microthrombi, and this can lead to prolonged kidney infection or kidney disability in these individuals with persistent disease and morbidity in these individuals. And lastly, we used to think kids were okay, they'll get over it, but there are persistent cases in kids of multi-system inflammatory syndrome, which gives them a severe reaction that requires intense immunotherapy in those individuals, and residual problems are seen even in children with this. It's not as frequent in children, but when it occurs, it is a significant problem. And we've all seen or heard of patients who are children who develop the multi-inflammatory syndrome. Now, how often does this occur? Well, this is a study that came out recently from Europe, and it's post-acute COVID-19 syndrome. The incidence in this trial, where they looked at all individuals of 277 people, all recovered from SARS-CoV-2 or COVID-19. And in those individuals, they found as many as 50% of the individuals who had recovered from mild or moderate COVID in the situation, and some severe, had persistent symptoms. These symptoms were, as we showed earlier, fatigue and dyspnea, but they also included cough and headache, with imaging abnormalities seen in about 19% of those individuals, and reduced spirometry. So the spirometry showed reduction and restrictive airway disease. So we have created a new group of individuals with a chronic condition, and that chronic condition is post-acute COVID that we're seeing. These individuals are symptomatic and they have severe disease. What can we do for them? Well, if we look at acute treatment options for SARS-CoV-2 or COVID-19, we had a lot of hope because we knew that there was at least 7 steps required, shown here, for the virus to not only enter the cell, get in there and begin replicating, and then assemble itself and release. So each of those 7 steps that are required to manufacture COVID-19 in your own human cells were subject to interruption. And if we look at the agents that were proposed, the first agents could block the entry for that, prevent the spike from contacting and getting into the cell, block replication of the virus inside the cells. And we had a number of agents for that, including remdesivir, agents that could boost the innate immune response that have been looked at, have been gone into trials, and enhancers of antiviral innate immunity that have been tried in multiple trials. So some of the trials are shown here that were done early on, and you can see a number of circles there where each one of these represents a set of trials where that particular agent was used. So although we had a lot of options when this came out, and we still do, literally the only trials that have really shown significant benefit are those circled in red, and that is the initial use of remdesivir. It doesn't cure the disease, but it may shorten the acute episode by several days and could improve mortality a little bit, was important. Improving standard of care for pulmonary was important. Proning and ventilation techniques were extremely important in reducing the in-hospital mortality by up to 50%, and that was certainly a benefit. And on the top left, we can see that corticosteroids in a number of studies now have shown later on in the treatment can prevent or reduce the cytokine storm and the exaggerated inflammatory reaction leading to disease. And by getting high dose corticosteroids, that can be reduced at that point in time. Of all the trials that have been shown here, those are the only 3 that have shown some benefit. And so we're relying now on vaccines, shown on the right. Vaccines is the window at the end of the tunnel that we're looking at. This shows of all the trials that were just discussed, here are the guidelines that are based on those trials. And you can see again in red, of all the possible candidates that have been looked at, it's only remdesivir and dexamethasone, a steroid, that have really come out and been effective, along with our supportive oxygen delivery and ventilation techniques. So those 3 have shown a benefit. The others have not yet shown a benefit, despite the fact that we had multiple areas that we could attack with that. These are the current 2019 treatment guidelines for coronavirus based on the severity of the disease when the patient comes in, if they're hospitalized, not hospitalized, or go to an ICU or require ventilation. And the sickest patients might require extracorporeal membrane oxygen or ECMO, which is our last option in these individuals. The light at the end of the tunnel is vaccines. And we were fortunate to have a lot of work done early on for vaccines for Ebola and other viruses that led to a relatively quick rollout of options for coronavirus vaccines. Shown here, there's the ones that are in blue circles shown on the right are the ones currently approved in the US, the Pfizer BNT and the Moderna, which both use an mRNA that is injected into the body in a matrix that allows it to get into the cells and stimulates our own production of the spike, and the spike then leads to the antibodies that our body makes to protect us. So we have both Pfizer, BNT, and Moderna, which are approved in the US. The lighter blue circle represents what will be Janssen, heard this Friday by the FDA to see if this particular vaccine will be approved. That vaccine works through an adenoviral vector, which is shown. So you take a relatively innocuous adenovirus and you actually code it so that in addition makes the protein similar to the spike, goes into a person, gets infected, and with one shot appears to stimulate the immune system to produce antibodies to get protection almost as good as the mRNA vaccines. And the third option is just to inject spike proteins, which is shown for both Novavax and Sanofi. And those have data in review trials right now for that. So that is the option that we have to hopefully get a handle on the surge, which is now declining, and prevent further people from dying. But because we've had millions of people infected with this disease, there are literally perhaps 20 to 50 million people in the United States who are susceptible for post-acute COVID. And we're now having to start clinics to just deal with these long haulers who come in with post-acute COVID-19, and to discuss the diagnosis, treatment, and management of these patients now that we're left with who are merging into chronic disease. We are delighted to introduce today Christian Sandrock, who is our best way of handling post-acute COVID because he's trained in infectious disease, critical care, and has in fact established a clinic to take care of this new entity that we're left with. A year ago, we had no idea how to handle post-acute COVID. Today, we're going to find out from Christian what we can do to improve the outcomes in these individuals and to deal with this. So with that, I'm happy to introduce, and I will turn my slide back over, turn share screen off, and we're happy to introduce Christian here. And we're delighted to have him. He actually made way for us today to out of an ECMO meeting that he was in, because now, as you can see, because of the pulmonary complications we've endured with the acute phase and that we have to be prepared for, there's a lot more need for ECMO, which is for the most severe respiratory patients who, even with ventilators, cannot oxygenate themselves. So I'm happy to introduce Christian, who is going to talk about post-acute COVID syndrome and what we do with it. So Christian, the mic is yours.
Perfect. Well, I think, I don't know how long you guys go to, and there may not be a ton of time left. But the good news is there's not a whole lot to say. And by the way, thank you. Let me make sure here. Oh, good.
I want to answer your question, Christian. So we often go till 6:30. It just depends. You know,
Okay.
We do have a good critical mass with us still. And thank you for being with us.
No worries. I just didn't know if you end at 6, how quick I can go. But
Take your time.
Okay, beautiful. And the beautiful thing is Dr. Bommer actually did a nice job of presenting about half to 2/3 of the slides I was going to talk about. So what I'll focus on here is probably more conjecture and opinion rather than data, because that's really where we're at. And, as Dr. Bommer mentioned, here at Davis, we've seen a need for managing these patients in the post-acute period. And you heard a nice overview of all the different effects, and I won't spend a lot of time on that, but all the different effects we see in our patients. What has become clear is that number one, we don't have an obvious, easy way to treat these people. Number two, the treatment needs to be individualized. So what that means is if we see one patient, as Dr. Bommer mentioned, that has predominantly cardiac symptoms, another one is predominantly pulmonary, a third is brain fog and can't really keep up. Those are all very different and individualized treatment modalities. And as of now, we don't have a simple way to manage them in one fellow swoop. So that's really become a big issue. Lastly, which is always a big push for us, is research. So the more we can get these patients involved, the more research we can do, the better we can find, or the more quickly we can find some treatment. So really, that was the avenue for preventing this post-acute COVID clinic. Now, interestingly enough, if you get referred to us, and I was on a meeting this morning very early. It was a East Coast meeting, so I got up at about 4:30 in the morning to attend it. And interestingly enough, as a byproduct of that meeting, I was requested to see 3 patients, one in Russia, one in Australia, and one in France. So what it really means, though, is that we really don't have a whole lot of clinics available. The only other one in the country that's named themselves as a clinic, and surprisingly, the Mayo and Cleveland Clinic have not, has been the Center for Post-COVID Care at Mount Sinai. We are actually working on our center status, hopefully in the next 2 or 3 days. That'll have research, outreach, and education, and patient care. And really, as you saw, the care is, multifaceted. So what's going to happen is if you come in and predominantly have brain fog or loss of smell, those are very different avenues. We might send you to neurology, ENT, obviously psychological services, or if you're having predominant cardiac effects or pulmonary, you might see one of us, or you might see Javier Lopez in cardiology. So this is the structure we're trying to create, where you can stop, get all that care, and sort of move on, and we can customize that care. But again, I'll mention a few things and a little bit of my biases, because us ID critical care guys are always a little weird. We're different than the cardiologists, and not always a good way. So I'll mention a few of those things, and without a big outline. And the reason I want to mention this is the struggle we're having with these patients. And, Dr. Bommer did a nice job of outlining the effects, but sometimes of COVID directly on, for example, on the heart or the lungs. But we struggle with really pulling out what is what. And some of the newer data that's coming out is helping. But you can sort of imagine, we can get an older gentleman, in this case, 76 years old, multiple risk factors for severe COVID, obesity, hypertension, diabetes, comes into the ICU, has hypoxic respiratory failure, gets intubated, he's on mechanical ventilation for a few months, gets hospitalized for 75 to 80 days. That means, as he's ventilated, trached, there's tons of deconditioning, lots of sedation, paralysis. Obviously, he would have gotten steroids and Decadron as well. So that means now, as we're seeing him, 2, 3, 4, 5 months out, when he has his weakness, depression, fatigue, decreased appetite, extreme forgetfulness, what part of that is his prolonged ICU stay, and what part of that is his post-acute COVID syndrome? And I think that's really the difficult part for us to separate out. We do know from any of your prolonged ICU stays, whether this is a cardiac event, trauma, H1N1, and other infectious disease issues, sepsis and urosepsis, for example, you can actually have many of the post-acute COVID syndrome issues that we're seeing, including depression, fatigue, lethargy, and forgetfulness. So separating those out have become key for us. But the other, which we've now started to get more data, and there was a paper that just came out a few days ago from the University of Washington. You can imagine a 31-year-old woman, no past medical history, develops acute COVID, maybe gets fevers, chills, body aches, feels poor for a few days. Now she's a few months out from those first symptoms, has intermittent low-grade fevers, dyspnea on exertion at a block, tachycardia, tachypnea, weakness, hair loss, fatigue, loss of her teeth, difficulty concentrating, and depression. So you see there's both of those patients fall under this post-acute COVID process, but one clearly never saw a physician, never was hospitalized, has these long-term effects. And that's a lot of the microvascular thrombosis, the direct effects of the virus on the myocardium, brain, and lungs that Dr. Bommer was talking about. The first patient, we really have to separate out what is the deconditioning from his ICU, what is the depression and other issues associated with the meds we've given him. So that's really where we're spending our time focusing. And I'll mention, this is just the struggle we're having in this clinic world, is you hear a lot of different terms, right? long haul COVID long haulers, post-COVID syndrome, and so forth. I will just put my plug in here that I like this idea, and Dr. Bommer was great. Talked about post-acute COVID and post-acute COVID syndrome, because that folds with two things. One is it tells us we're not infectious, right? It's after that acute phase, usually when you're 2 to 3 weeks in, you start to become less infectious. Definitely by 30 days or so, if you're immunocompetent, you're not going to be infectious. That's why the CDC has a cutoff of 21 days from first symptom onset. Just we know your likelihood of being infectious is low. So again, this is not an infectious disease. This is a sequelae of that infectious disease. And the rest of them, whether it's continued or long haul COVID, it just is nebulous and doesn't really give us that backbone and so forth. So now the definition has become challenging. So some of the studies Dr. Bommer presented all had variations. When we talk about the idea of acute is really from symptom onset to about 3 or 4 weeks. Post-acute starts around that time. And where that sort of transitions into a more chronic phase is open to debate. Some of the studies looking at the incidence and risk factors were at 60 days, some were at 90, some are at 180 days. We sort of as a consensus are now saying that around 60 days, if we see persistent symptoms that are classic, which I have listed below and I won't go over since Dr. Bommer went over most of that, I think that becomes really important for us to say, okay, about 60 days, you're really transitioning to that post-acute COVID syndrome process. Now, the other thing which has been extremely challenging, and this leads us to separate out a number of our other patients, is what do we do if you don't have a positive test? So you can imagine we've all seen patients, and if I were to go to my rheumatology colleagues and say, hey, I got a few cases of fibromyalgia for you, they usually groan and they totally dislike seeing those patients. In ID, you can mention chronic fatigue. There's just a lot of overlap with those types of patients with what we have here. And how do you separate out, again, what is post-COVID or not? It'd be great to have a positive test. And if you had a positive PCR in the acute phase, if you had positive antibodies after, that really helps quite a bit. And I'll show you some data in a second. The detection of antibodies really makes it difficult in that diagnosis standpoint. So to really say that's the case. And then testing was very poor prior to early April. So many people didn't get tested. Serology was not well developed. A lot of the PCR tests we had were limited. So really before April, that's a hard group to manage. After April, we may be able to say, hey, we actually have some testing and we can link it to an acute infection. And that's really what we have to spend a lot of our time. So I saw a patient recently, early March, was in New York City, ended up having what sounded like classic COVID, never had a test done. So sometimes we sort of have to hedge our bets and hope that that's what it is. In other cases, could this be more chronic fatigue and overlap with an autoimmune disease? How do you tell the difference? That's a lot of the workup and treatment we need to do, is really trying to separate those out. And, if we can treat and find that this patient has a more clear autoimmune process that's separate from a post-acute COVID syndrome, we can then focus on treating that, because at least we have data of what to do in those cases. Same with cardiac and pulmonary and other functions. So these slides, I didn't know Dr. Bommer was going to mention how common it was. So I don't have to spend a lot of time, which is perfect. We can leave more time for discussion. But this was the study out of Wuhan, and Dr. Bommer mentioned it briefly, that was presented in Lancet. So you can really see that a lot of these patients were followed up with either, at worst, a 6-minute walk test and some laboratory tests. At best, they got CT imaging, ultrasonography of the lower limb, and pulmonary function tests. There were a few things I wanted to mention, and really this third bullet point is probably the big one. Now, the issue is that most of the data we see coming out with patients and sort of describing the incidence really describes the incidence in patients who are hospitalized with moderate to severe COVID, mostly in the ICU. And again, that then becomes difficult for us, which is your ICU stay, which is not. And the reason I'll mention that's important and why I'm harping on that is, the data you saw from Dr. Bommer showed that, you can have extensive myocardial inflammation in this post-COVID period. If you have that versus someone who's deconditioned from a prolonged ICU stay, my treatment for you for rehab is going to be vastly different. I'll push a patient who's deconditioned. I'm not going to push a patient who's got microthrombosis, myocarditis, myocardial inflammation, and is at high risk for an arrhythmia. So that how I manage that period of rehab is going to be very different. So that's why we want to sort of separate those out in our diagnostic periods. We kind of went over this data here from Wuhan showed that about 3/4 had symptoms at 180 days. But again, these were hospitalized patients. But that third bullet point, that a little more than half of them had seropositivity at 180 days, that's the part that's difficult. So within the first 2 to 3 weeks of their infection, 92% had seropositivity. It drops to 50% by 180 days. Now, that doesn't mean you're not protected. That doesn't mean you're not going to be able to mount a response and fight off even a newer strain. But what that does mean is it's harder for us at 180 days onward to rely on serology. So if we have positive serology, great, we can sort of at least diagnostically put you into that category of post-acute COVID syndrome. If your serology is negative, again, we sort of have to work a bit more closely to figure those things out. So I think a lot of this data we talked about, and I'll sort of hop through. This is the data here, particularly on this right side, showing how neutralizing antibodies declined at 180 days. And I think that's the take-home message, is we can't always diagnostically rely on serology to say you've been infected. This data here, the only thing I want to mention, which is interesting, this was a telephone follow-up of 1,200 patients from Michigan. And again, in the next slide here, this is sort of the breakdown, and Dr. Bommer went over most of those. The big thing, though, is many of these were healthcare workers. Many of them were young, but the financial and economic stress was great. So about 85% of them were unable to fully work or reported extensive financial stress. And that's one of the other things that's really become key, because you can imagine, as we deal with brain fog and depression and a lot of psychological effects of COVID, how do you separate that out from the fact that you're having financial stress and all the anxiety that that stress brings in the post-COVID period? Or more importantly, and I will tell you personally, if I end up being unable to smell and taste my coffee in the morning, you better believe I'm going to be pretty depressed, right? So how much of this is a reactive depression from the effects of what we're seeing with chronic illness? And again, that is all treated very differently. So our diagnostic skills, we have to pull those out, and sometimes it's nearly impossible. You saw this slide with Dr. Bommer, which is great. But again, I think the big commonality is, how do we sort of separate out those that have ICU stays versus those that don't? The letter from Washington State, which came out recently, was quite nice because it followed up about 170 patients, actually 177. And I'm sorry I don't have those slides here because the paper just came out. But actually, a third of them had ongoing symptoms. So that's probably the best and most robust data we have for patients who are not hospitalized, who have symptoms of acute COVID. Some have reported downwards of 10 to 20%, as Dr. Bommer mentioned, but we are certainly seeing that these patients are going to have some symptoms. So it's really quite profound overall. Risk factors we talked about and some extent. I think the big things that we see, and here's an adjusted risk factor from this MMWR paper. And interestingly enough, I highlighted in there that hypertension, a BMI greater than 30, and having a pre-existing psychological condition were the biggest risks. So actually age, ICU stay, severity of illness didn't really correlate out once we had an adjusted odds ratio, and this was evaluated by regression analysis. Now, the hard thing is the psychiatric condition labeled here. All that really means, if we're more likely to have anxiety or depression, or even have an Axis 2 diagnosis or more open psychosis, that's going to be worse afterwards. And again, it's hard to know, because we know that there's a direct effect on the CNS of the virus. We also know that this could be very reactive to your certain life circumstances, which is pretty hard. And that's mostly what we want to mention. Now, the anecdotal risk factors I do want to talk about, and as we manage these, unfortunately, my life has been all things COVID since last March. As a critical care doc and an ID doc, that's pretty much all I've taken care of. And honestly, I'm pretty tired of it. I can't wait for just to have a normal patient. We had a patient with a meth overdose recently, and I felt like a case report. I was so excited that I actually just had somebody who had methamphetamine overdose. Finally, it was not COVID, which really says a lot about the way the last year has been. But I think what we've seen is that obviously patients who in the acute phase have a lot more clotting and inflammation. So those patients, DVTs, PEs, a stroke, acute MI, those we see a lot more inflammation, particularly cardiac and pulmonary in the post-COVID period. Again, the ICU stay is a risk. And then interestingly enough, we've seen that a lot of mild disease, particularly loss of taste and smell or chest pain, seems to be a pretty big risk factor for these patients having post-COVID syndrome. Now, again, that's my bias. I really don't actually have a lot of other issues, but interestingly enough, and there's 2 unpublished papers, I just reviewed one from Duke that shows, obviously when you lose your sense of smell, that's a direct infection and a direct effect of the virus in the olfactory nerves. We do see that your frontal lobe can actually have some, direct, the virus can directly affect your frontal lobe and can actually cause some mild edema. We also see the same in the brainstem. So when we see our patients who have profound respiratory drive before they're intubated, we've always attributed that predominantly to hypoxemia and the fact that they may have, obviously macro and microvascular disease. They're shunting. This is a response to that. There actually may be a direct effect on the brainstem affecting heart rate and actually affecting respiratory drive as well. And it remains to be seen, but it's been pretty interesting overall as we kind of look at that. So, again, I will mention only one thing here is the dermatologic. Again, Dr. Bommer went into most of these, but we are seeing a lot of rashes, and pretty much just about every rash, not that classic COVID toes that was all over the media back in April and May. We are seeing that you can have microvascular disease like that, but common rashes, all sorts of common rashes, lots of hair loss, teeth loss. So those are sort of the big dermatologic changes we're seeing in about half of our patients, which again, this is not commonly reported as it is with the olfactory and other symptoms, but about half of our patients have some form of dermatologic change, which we're seeing. So I kind of went over both of these in general. The only thing I want to mention, and I know Dr. Bommer went into this, but there is some data looking at why this may be. I mentioned the prolonged ICU stay and the complications thereof. So just that deconditioning and the effects of all the sedation. The microvascular disease in this post-COVID period is very hard to diagnose. Now, for example, if we see one of our patients, if they come in and they have large vascular disease and we see a PE or a DVT or an arterial clot, that's pretty easy. And that's what we've seen in the acute phase. But many of these patients have what's called microvascular disease. And we've seen that on post-mortem examination for these patients, as well as direct, myocardial and pulmonary or lung tissue examinations. Where we see that on testing, though, is where it's much harder. So in my patients, if they come in with shortness of breath and or chest pain, the first thing we'll do is we will actually get a pulmonary function test. If their DLCO or diffusing capacity is very low, and we don't expect them to be, particularly if they're 30, 35 years old and they don't have any underlying lung disease, that's a first sign that there's some form of fibrosis, but there's probably microvascular disease. We can also put these people on a bike and do a cardiopulmonary exercise test and tell what part of that is actually a cardiac or pulmonary limitation. There's a number of different PET and other MR imaging of the myocardium, which can actually show that inflammation. That's really what we're often using. But again, the big question is, what do we do with those results? And I'll mention that in the end, but that's probably the hard part is these patients have microvascular disease. It explains why their symptoms are what they are, but knowing what to do is obviously very difficult. Autoimmune process, I'll show you a paper in a second that there probably is an overlap in that acute inflammatory response where you actually get some collateral damage long-term. This drives a lot of the skin reactions we see, the muscle pain, the fatigue, and the joint pains. And then obviously a direct infection of the virus. We know it affects just about all tissues, particularly through the ACE receptor, but we know that the CNS is also very heavily involved in these cases, and that plays a big role as well. The only take home from this film or this piece from a paper here is you can sort of see those circles on the right-hand side. Those patients that had low inflammatory markers, in this case CRP, had low rates of ANA and RF rheumatoid factor after their acute COVID. If you notice, they had a relatively high CRP and signs of high inflammation. Those markers were much higher. This is one of the first studies to sort of look at the autoimmune process. And we do know, for example, from chronic fatigue syndrome and to a lesser degree, fibromyalgia, that is an autoimmune process that may be post-infectious as well. So we see a little bit of overlap there. Dr. Bommer did a great job of talking about the microvascular disease we see in the lung. He actually showed this paper as well from JAMA Cardiology, so we can sort of hop through that, which is really makes it much easier. This paper here, which I'll sort of go through, is the psychiatric side. And I want to really show you this data here. So when you look at the age distribution, this was actually a study cohort versus the government public health cohort. This was actually done in the UK and really wanted to show, okay, where are we seeing a lot of our psychiatric illness? And you can see here that it's pretty evenly distributed across all groups and all age groups. And that the study cohort tended to have much higher rates of psychiatric disease in the acute phase that you're seeing here. So again, this is the acute phase. When you, on figure 4, when you looked at the chronic phase, you can see that actually the neuropsychiatric disease was more prevalent in the younger. The cerebrovascular disease was more prevalent in older populations. So we're seeing some trends that in this post-acute COVID phase, we're seeing more vascular disease in the older, we're seeing a lot more neuropsychiatric disease in the younger. And I think that's the interesting part that's driving some of this. I won't spend much time in here because again, discussion is always much better. But if you note, this is just a sense of the edema acutely on the left, more chronically on the right. That's associated with a loss of smell. You can see that little yellow circle on the right side shows actually the encephalomalacia associated with loss of the olfactory bulb and the cribriform plate. And again, we know that data very well, particularly here. A lot of complaints associated with olfactory limitations that are not as readily present at 1 month. We can also see that, again, your ability to sense smell goes up much more as this time goes on. Now, the big question is, does that resolve? We are seeing a group of patients where it doesn't resolve. And what to do with that subgroup is going to be very difficult as we go forward. So, so where does that leave us with treatment here? So I have the first dot, which is a bunch of question marks, because I think it's really difficult to know what to do. But what really should be in that place is treat what we know. So again, if we're going to see a patient and they have cardiac limitations and they're having arrhythmias, we treat the arrhythmias. If we see a patient who has brain fog and depression and anxiety, we're going to treat the depression and anxiety with an SSRI. So we're going to, obviously, if you have microvascular disease and you have, a DVT, for example, we're going to treat you with anticoagulation. So we know that that's certainly the first step, is really to evaluate these patients, particularly with PFTs, cardiopulmonary exercise testing, and certainly with any further cardiac imaging as needed. And we treat that accordingly based on those symptoms. The other thing, though, is time and patience. So many of these patients are used to having an infection. After the infection, they get better in a few days, and then they sort of move on. These patients have lingering symptoms, and their improvement is glacial at best. So many of our patients will notice that there's a few steps forward, a few steps back, a few steps forward, a few steps back. And that can be profoundly demoralizing, where, at least 3 or 4 months in, depression takes over for many of our patients. So letting them know that, hey, don't measure how you do day to day, measure how you do month to month or every 3 months. So my, a patient I saw earlier today in clinic in Davis, they were very nice, and they're like, I don't feel any better. Well, hey, when I saw you at your appointment 3 months ago, you couldn't get up a flight of stairs, you had chest pain, you were on oxygen. You're off oxygen, you can walk down the hallway, you can walk up a flight of stairs, and you still have a little chest pain, but that's some improvement in 3 months. Not great, but it gives them something in a benchmark that's reasonable. Not a lot of data in the post-acute stage with anti-inflammatories or immune modulators. I don't know if keeping steroids on these patients longer is going to help. I don't know if that's going to make a big difference. There was an RFA that was released at 2:00 today to look at post-acute COVID syndrome with the NIH. So we'll be submitting at least one with our clinic population to take a look at, managing these patients. What's the best way to manage them? Are some of these immune modulators and anti-inflammatory agents going to make a difference? So the last thing I'll mention is we work with a lot of patients who are employees at places. So disability has become a bear for us. So, obviously when you have brain fog or you have some non-specific symptoms, does that really mean that you're disabled or not? If you can work for 2 hours and then you need to take a nap, which many of my patients do, how do you manage that? So I think that's really the issue that we're trying to manage with these last few patients, and it's made it particularly challenging overall. So anyway, with that, I have questions and certainly here to support, and thank you for listening to me babble. Dr. Bommer stole the show and had many of the data I was going to present, so he made my job easy, which is wonderful when you come from an ECMO meeting, which we still, by the way, have 4 people on circuit from their acute lung injury from COVID, and they're now at past day 60. So that's a whole nother story to talk about if you guys are ever interested. So anyway, well, thank you very much for listening. I appreciate it.
Well, thank you very much, Christian, for that. We'll open this for questions. A couple that I had to lead is, what do you need to start a clinic? What facilities do you need? What access to testing and other things would make sense if you're now going to start a new clinic for that? And what would other hospitals or physician groups need if they're going to consider this? Because we do have, or will be seeing, quite a burden of individuals with this post-acute COVID. Yeah,
it's a great question. And I think, having some multidisciplinary coordination, I think, is key. So, again, we're going to see these people presenting to neurology, psychiatry, pulmonary, cardiology, all of them. So to have a central coordination, I think, becomes helpful. That's what we're trying our best to do. So if a referral comes in from the outside, we might be able to say, hey, this is best served by seeing neurology first. This is best served by seeing cardiology first. So this way, there's not a cardiologist or a pulmonary doc who, doesn't really get to see their disease. Maybe someone goes to neurology and they're hypoxemic. I love my neurologist greatly, but if they're going to see someone who's hypoxemic, they may not know what to do to the same extent that, we do in pulmonary and cardiology and so forth. So that, number one, I think that gatekeeper becomes key in getting the patients to the right place. And maybe that means, for us, that might often mean seeing us in pulmonary. And we say, you know what? we hear you. We know that you certainly have disease, but right now what predominates is your neurologic symptoms. Let's get you over to neurology, but we're not going to ignore the other stuff. And then you sort of become that gatekeeper. The second which is a great question, and we're sort of figuring this out, is do we need to have all those resources? So pulmonary function testing, all the resources that come with cardiac imaging and advanced cardiology studies, MRI and MR imaging of the head, neuropsychiatric testing. Do you need to actually have all those things available to you at your clinic? And the answer maybe not. So as we see some people coming from Kaiser and other healthcare systems, we may be able to actually facilitate, see the patient, say, hey, get these tests, and then they come and see us with the results, and we can help facilitate that for a primary care physician. So that second part, we're still debating how much we want to control and how much we can actually get on the outside. But I think, having a place to see these patients, and then obviously having an ability to get some of those test results, even if they're done on the outside, I think is key. The same gatekeeper who decides where they go, for us, they're actually spending most of their time getting test results. So Care Everywhere that we have in our Epic is great, but it may not get everything that we have. So I noticed they spend a ton of time just getting records so we can actually make a good decision and not reproduce testing for our patients.
Great. This is Ed Yu here. Great talk. So I'm from Palo Medical Foundation, more in the ambulatory space. So I'm curious, are we at a point that we can have some predictors to identify which cohort, and I'm particularly interested in the non-hospitalized symptomatic COVID patients who are at higher risk of having a post-acute COVID syndrome? Are we at the point that we're starting to glean some insights, what patient characteristics or what clinical conditions or whatever there may be that help to inform this? Thank you.
I wish. And unless there's data I don't know about that's not quite yet published, the answer is no. We don't really actually have a good group of people that we're able to say and look at when they're in the acute phase of their COVID to say you were at high risk for having these prolonged symptoms. We actually don't really know. And it's been exceedingly surprising. The people I thought would have done very poorly with their acute COVID don't. And some of our patients who I think would be great are not doing well. And it's really, that's the thing that's been most surprising with SARS-CoV-2 is the irregularity with what we're seeing symptoms. And, I wish I had a great calculation. We talked about this the other day. You know how you can go on the Hopkins website and you can punch in some of your patient's findings and you get a sort of an acute mortality score of what your patient's likelihood of dying in the next, 7 through 30 days is. I would love that for the post-acute COVID syndrome. So, hey,
exactly.
In the acute phase, let's plug some in. Let's tell me what the likelihood is. I have absolutely nothing. I mean, I saw a 91-year-old and a 19-year-old today, literally anagrams of their number that both had acute post-COVID syndrome. And actually our 91-year-old was doing better than the 19-year-old. So it's really all over the map. It's kind of depressing, actually.
Thank you.
Yeah, no, of course.
Christian, do we have enough information now that we could put together, or you could put together, a flow chart when individuals come in, and you could go through stepwise questions? Have you been in an ICU for 180 days? Well, then you go this way because now you may have, ICU related disease. And if you less than that and you have the same pulmonary complaints, then we would want to maybe get a DLCO or pulmonary function test, or that could be stepped through, because we have a lot of people in the state who have this, a lot of physicians who it's very new information for them, that if we had some type of a guideline with a flow chart, people could say, hey, when this patient comes in, I don't just scratch my head. I can look at the flow chart and do a stepwise approach to perhaps straightening this out or getting closer to it.
Yeah, that's also a great question. So we actually do have one. We want to put it up on our website for Davis. It's currently in the office where whatever black hole it goes into within the office of approval here, which means, sometime in 2022, I might see it approved. But with that being said, there is actually a process that we're making some recommendations. As you know, when we say this is what we think you should do, it's a lot harder to do on your own website, particularly when this is the post-acute COVID clinic website. I think what you basically described is the manuscript I started writing this week. So I think that would really be key, is to get a quick review article. The data is changing all the time. Where are we at? What are the basic tests that a primary care physician or the first physician seeing these patients should order to get that ball rolling? What do you need to think about? So, and that's a safer place, because I could put that into a peer review process, and I don't have to worry about approval internally. So I think that's really where we probably need to go. Great question, because there's no consensus on the way to manage these people. I will tell you that my colleague, Dr. Ldl Average, does it slightly differently than myself. In the end, we sort of get to the end result, there. I tend to be more of a person that questions, what the heck am I going to do with the data? And if I put you on a bike and we do a CPAT and we show that it has a cardiac limitation, is that going to change how I manage you? And if the answer is no, and I already know you have deficits there from other imaging, I'm not as excited to do it while all my colleagues put everyone on a bike because they just like doing it. So I think we're still struggling with how to come, the importance of those tests. But great point, Dr. Bommer. I think we need to get there for sure.
So, Christian, this is Joe Sky. I would like to add to what you say, just from a very practical perspective. My observations helping out in the ICU in Fresno, which is a UCSF affiliated program.
Yeah,
they had, if I recall the numbers correctly, they had over 400 patients signed up for the post-COVID clinic. But the problem was that the critical care doctors were still so busy in the ICU that it was very difficult to even start seeing the post-COVID care clinic. And then I think that something that I did not recognize, it's one thing for me as a cardiologist to see a COVID consult, 2 or 3 weeks after the patient has been infected, and I feel very confident it's safe. Yeah. One of the problems we were having is community physicians who were not in the trenches like you are very afraid to see post-COVID patients. And so the common theme was these people can't even really get in to see somebody. And the reason I think it's important to mention that is that until you're dealing with COVID on a day-to-day basis, the realities of knowing how to stay safe are foreign even to physicians.
Yeah. No, that's a great point, is the safety of, when are these people safe to come in your clinic? When are they safe to be seen from an infectious disease standpoint? The other thing, which, people ask all the time, okay, how many patients do you have in your clinic? How many are you seeing? And the ironic thing is we don't even know. And we don't know because there was no actual ICD-10 code that we can tag to our appointment until 2 weeks ago. So now we're trying to go back, and I'm trying to find my old patients just so we can get a sense of what our volume is. This was really not even a diagnostic code we can enter, right? I could get acute COVID or COVID with respiratory complications or COVID with cardiac complications, but nothing that I could really put in until more recently.
Yeah, and I think that from what I'm seeing, at Travis, we're lucky because we are co-located with our pulmonary critical care docs. We're actually in the same clinic under heart, lung, and vascular. And, we're seeing that we need to see these patients together. And as you appropriately pointed out, it's also neurology, and it's also going to be mental health, and it's going to be physical therapy and occupational therapy. And we have a huge challenge ahead of us that I don't even think we've even started to recognize how serious it's going to be.
I would totally agree. It actually scares me a little bit. And I have almost no outpatient presence in my clinical practice. I'm almost solely an intensivist and an inpatient ID doc. So to start to do this in clinic while I like it, you're exactly right. I don't even know how I'm going to see these people. I can barely get a half day of clinic in, and that's not going to make it dent. So we're trying to get a group of us that can at least, get a few days a week to fill in, but it's going to be pretty profound over time.
Well, having been in the intensive care unit recently, I agree with everything you said. You did a great job. Thank you very much.
Yeah, this is Ed. You hear great. I want to bring up, from your experience, to what degree, or do we know that patients with minimally symptomatic or asymptomatic COVID, is it possible for them to have a post-COVID state analogous to what you have mentioned? Is that theoretically, is that possible?
I guess theoretically it might be. But that's a great question. So most of these the studies we've seen, and even just this Washington State letter, everybody's been symptomatic. So if you see somebody who's minimally symptomatic, or who's an asymptomatic asymptomatically tested and positive on screen. So here at Davis, in the city of Davis, you can walk in and get your saliva test up to twice a week. So we actually get a number of people who have a positive saliva test. They feel nothing. So that subgroup has not really been studied. We think they probably are not going to have a very high rate of post-acute COVID syndrome, but we really don't have a whole lot of data. So most of the people that have been reported, and the one study, the Mediterranean study that Dr. Bommer showed, this study from UW, they would have been classified as mild to moderate outpatient. So they still have symptoms. Most of them were febrile. Most of them had some cough and shortness of breath. So the people who just kind of feel like they're a little off for a day or two and they have a positive test, or they lose their sense of smell but nothing else, that subgroup, I really don't have any data for you. And that's a great question. And that may be one of the big risks, is severity of symptoms and prediction of post-COVID.
Yeah, on that note, my final question is, under case, the presumption is that the post-acute COVID state, the magnitude of the symptoms is going to be less than the illness itself. Are there cases where it's not, where they had they're symptomatic with COVID, but the post-acute is symptomatically worse than the acute phase?
I can speak, I don't know of any data specifically. I can speak anecdotally that I have quite a few patients that their post-acute symptoms are worse. I do think some of that is the fact that they were sick for a few days, sort of mellowed out, and then their symptoms worsened. That, this is like a marathon compared to a sprint. So now they're going on 3, 4, 5 months of ongoing symptoms. The symptoms might not be severe, but the longevity is really killing them. And so I haven't been able to separate that out in the patients I've seen.
Wow, fascinating. So much more we're going to learn from this. It's becoming a chronic illness.
Yep, a lot of data, and it's our new fibromyalgia / chronic fatigue.
Oh no,
the disease that's going to keep me in the ICU more because I don't want to do clinic. so yeah, it's a hard group.
And thanks so much, Dr. Sandrock. This is Nerali. I'm the resident neurologist, I guess.
Oh,
no, I know.
Beautiful.
So
I have to insult one.
neurologist.
You have to insult me back, so that'll be good.
No, we have only left. So I guess I have a question, a comment. The comment is, I think now that this is so common, I'm wondering if the post-COVID care clinic should really be run through primary care as really the clearinghouse, given everything everyone said. And I don't know, Ed, what you feel about that in this space, but it seems like this is the new chronic illness. This is so common, and it shouldn't require a subspecialty center, but it should be actually primary care that can refer and be aware of what to look out for at post 60 days. Ed, maybe you can comment back on that.
Yeah, I think once we get to a point where some care pathways or guidelines, I think that's feasible. But if not, what do you think the primary care is going to do? They're just going to refer it out.
Well, that's what Dr. Sandrock is doing.
Right. But I think that will become the state, but I think we just need to learn more where we have some sort of guideline that we could follow. Thanks.
Exactly. And then I guess on the neuro component, there's a lot of data still coming to pass. And I think you're right. We don't really know. In neuro, we sort of say, we often think about steroids and what role it might play. And I saw the recent tocilizumab data that didn't really pan out in the acute setting, but I'm wondering, it's not exactly parallel, but for HSV viral meningitis, when there is persistent post-viral inflammation, we have seen antibodies in the CSF, right? The NMDA receptor antibody encephalitis, sort of persistent, that is responsive to steroids or other immune modulators. So do you know if there's any data, and I'm not aware of any, about uptick in inflammation on CSF or antibodies that are being seen as a way that we can move forward, perhaps?
So Quan Ing, who's one of our neurologists, called me about that around 1:30 today with exactly that question. So, what data do we have? And actually, I can't find any. So I have to admit, I was sort of multitasking with a few meetings around 2 o'clock. I did a quick lit search. I have not seen anything. But, you bring up this good point of, HSV encephalitis, West Nile virus encephalitis. And you probably see, Dr. Vora, you probably see a lot more people than I do. But on my ID side, when I've seen a few of these people, a lot of the brain fog and a lot of the ongoing symptoms now, months after their encephalitis, is pretty similar to what we're seeing in COVID. So there is a not exactly, but a pretty significant overlap. So I wouldn't be surprised if they had elevated protein, elevated lymphocytes, and detection of antibodies and so forth.
Yeah, so it'll be interesting to see how that pans out. But that could be, Ed, you're wondering how are we going to treat these people? What are we going to do when they come to clinic? But maybe that will be a way forward. Although I recognize that there's not enough data yet in the post COVID setting. But thank you, that was a great overview, and I think it's important to recognize how multidisciplinary this is, and it's really all hands on deck still.
Yeah, that's what's giving me a lot of stress, because I have quite a few neurologists interested. I don't have very many psychologists interested. So that's our big gap. So right now.
I did see one question come in that nobody addressed, which is about convalescent plasma and whether there's any value to that.
The answer is maybe. So the data on convalescent sero is not quite as good as the data on the monoclonal antibodies. So, and I think the monoclonal antibody data is going to show, and we're seeing more data come out. It's going to show two things that, pretty much the way Regeneron did it, where you have multiple sites, on the spike protein is going to be the way to target it, particularly as we have these new variants. But really the data supports high-risk patients with minimal symptoms as an outpatient. The question we had recently is, if you get a monoclonal antibody, is that going to lessen your likelihood of getting a post-acute COVID syndrome? I have no data for that, but that would be wonderful to take a look at. We've given about 120 people antibody infusions here. Again, all outpatient, high risk, otherwise minimal symptoms. And that's really where the data lies. Acutely, we don't really touch convalescent sero or any of this monoclonal antibodies. Great question. All good stuff.
Christian, that was an excellent presentation. This is SARS-CoV-2 is our third coronavirus of severe effect coming from animal population. How long do we have before the next one moves from zoologic to human infection?
Oh, that's $1 million. That's predicting the earthquake in the Bay Area. Good luck with that. You just know, you sort of know over time it's bound to happen. So, we do know that, and this is more influenza data, we know that pandemics generally happen about every 30 years. So when we went from 1918 to 1957, which was, the H1N1 to the H2N2 pandemic, that was a long gap. And then in 68, we obviously had H3N2, which is this byproduct of the most common one we see circulating today. And then you had that long gap from 68 all the way to 2009 when H1N1 resurfaced again. So there's sort of periods where you get a little stressed out and something's going to resurface. So but that's all based on influenza data. Here we have a coronavirus. There are other viruses that can sort of mutate, mix, and sort of jump from the animal side and domesticated animals into humans. And that's a great question. There's a lot of study in this area. There's been a lot of money put towards it, but predicting it is going to be tough. My first grant that I had was actually studying risk factors for acquiring avian influenza in East Africa and Asia. So, we didn't even really question how you can predict it. We just said, what the heck can we do when you have no running water and you're at a live bird market in, central Rwanda or the Congo? How can you protect yourself? And that's where we focused, and most of our funding was, NIH, and then that program was picked up by USAID. And that was actually fun to spend some time with, but, it's hard. People don't have very many resources. Good luck in getting them to, protect themselves and choose the right animal to process and eat and so forth. It's difficult.
Yeah, we got a question in the chat as we wrap up here. So the question is, it has been suggested that the presence of virus in the GI tract causes the long hauler syndrome. Any comments on that? And also, could you comment on the use of ivermectin and colchicine in these patients? Thank you.
Yeah, I have heard a little bit, and I have no comment really on the gut microbiome and the effect of the GI tract. We do know you can detect virus, and it can be shed through the GI tract. That was a big reason our GI doctors. So if I want to pick on any specialty, I should leave the neurologist alone, pick on the GI doctors who wanted to wear PAPRs when they did colonoscopies. And I thought, if you're aerosolizing stool, something's gone completely wrong in your colonoscopy. But that was at least my initial ID thought. But, you know, there is some data behind it or some theory behind it, but I really have no knowledge of how to, you know, how, if that's going to be an impact. And it really may be, because, you know, gut regulation is really pretty profound. Now, ivermectin and colchicine, I'll comment on colchicine first. There was an unpublished, unpeer-reviewed paper, which is undergoing peer review now. There should be another one coming out. The first one was looking at colchicine, you know, twice a day for 3 days and then a full month in patients with mild disease as an outpatient. And the data actually looks pretty good. Again, not peer reviewed. Yeah. The data I can see in the pre-submission manuscript actually look pretty positive, enough so that on a few of my outpatients, I have actually prescribed it. In the acute stage, when patients are hospitalized, I have not seen that data yet, but in theory, colchicine may be beneficial. Ivermectin, besides the political implications that ivermectin carried with it, the two studies that came out, particularly the one in Bangladesh, had a lot of gaps in how they were randomized and managed. So really right now, we've not really latched on to ivermectin, and, you know, it needs more rigorous studies like, you know, like we saw with the Solidarity trial that, you know, pretty much eliminated hydroxychloroquine and certainly removed remdesivir from more severely ill people. I think that needs more study before I comment on that. Kind of in a similar manner that we've done with colchicine. I mean, in theory, it's one of many things like hydroxychloroquine, which has an anti-inflammatory effect. And will that be of benefit? It just needs to be studied. So I have not really gone anywhere with ivermectin yet. It did get some political press, and Paul Merrick's group, you know, which is a critical care group, was really pushing it early on, but it really hasn't gone very far, and we've sort of left it that way.
Thank you.
No, good questions.
I think we've gone overboard, actually, 6:36. So we really appreciate all of your effort and everything for that. I think that we want to thank all the speakers, Eddie, certainly for presenting us with some really provocative information about screening in potentially lower risk individuals. And I think we can't wait for Eddie's publication to come out or to sneak out with his new recommendations and guidelines. And similarly, we've been totally impressed by Christian and your overworked presentation, because we know you're fitting us in between hundreds of patients and other duties that you have for that. And likewise, we can't wait to see your publication looking at perhaps early guidelines on how to treat post-acute individuals. In the
I might have spoken too soon there.
In the meantime, we're all left with this large number of patients that at some point is going to come in and actually demand some type of treatment or management. And I think we all know what's out there, and it's not really going away. And as you say, there's more patients out there than we can actually count right now that will have this problem. So we certainly want to thank everyone for joining us today and going over this. And Hattie, I'll give you the last word for
join us again on March 8th at noon California time. We're going to have Deepak Bhatt from Harvard joining us to talk about the breakthrough Reduce It trial on icosapent ethyl. And our dear Evelyn Stock was not able to be with us due to a family emergency, but she's working in a research area that has some potential positive implications for icosapent ethyl in even in COVID. So it'll be a wonderful learning session. Thank you so much, Dr. Bommer, for recruiting Dr. Bhatt, and Dr. Nathan Wong for our March 8th session. Do you want to say anything further about that? A little teaser?
Yeah, we obviously if we go back to the old type of disease, the atherosclerotic disease, we have a lot of treatments that improve people, but a lot of residual disease. And Deepak is going to go over some more recent trials done, completed in the last year that show additional therapy, lipid therapy for individuals with dyslipidemia and atherosclerotic disease. And we'll bring into focus what fish oils or omega-3s can potentially do or not do, depending on how they are presented to the patient as either pharmacologic doses or mixed doses. So there's a lot of new information there with the potential benefit of reducing cardiovascular events by an additional 30% when added to statins and other obvious lifestyle improvements that are required in all of our patients. It's possible that COVID may slowly go down as the current wave is going down, and we'll see less of it, and then we'll be left with our usual atherosclerotic disease to deal with. But potentially we'll still have residual patients. And as Christian pointed out, hard to sort out the ICU-itis versus the residual COVID problems. We'll have the same problem as we go forward with at least cardiovascular disease. How much of this is new atherosclerotic disease versus residual that could be left over from COVID? And I'm just terribly afraid that the scarring of COVID may potentially last, because so far we have very few modalities to reduce fibrosis. If you have pulmonary fibrosis and cardiac fibrosis, as Christian said, those patients are not going to get better overnight or over the next month. It may take months, if not longer, for them to show gradual improvement. So with that, hopefully all of you go out and continue to practice isolation, mask wearing, and have hopefully early access to vaccines so that we can keep the group together to handle the enormous problems that perhaps lie ahead with us. So we certainly want to thank everyone today for the program, and we look forward to the early March program where we'll be addressing atherosclerosis and the potential of new lipid dietary mechanisms and medicines to further reduce cardiovascular disease. With that, we're over time, so let me let everybody off and have a good dinner. And as Eddie says, make sure you get your 15 minutes of intense exercise today to level out before you have your glass of wine for tonight. So to everyone, here's to having a great rest of the evening.
Look forward to collaborating with you, Eddie.
Thank you so much.
Thanks,
Thank you.
everybody.
I'm going to go get my wine right now.
Wine and coffee. Thank you.
Good night, everyone.
Good night.